I'll start. Just have a look here. Listen here, I'll start. Now, this muscle which begins from the transverse processes of the lumbar vertebrae, the muscle which begins from the transverse processes of the lumbar vertebrae, and this muscle which comes down. What is this muscle known as? Psoas major. Psoas major. Now, this is the iliac fossa. I'm starting from the beginning. Just listen here. That's the iliac fossa, and this muscle is known as the iliacus. Iliacus. Now, this iliacus is covered by a fascia. What is this fascia which covers the iliacus? Fascia iliaca. Fascia iliaca. Now, the same fascia iliaca covers the psoas major. The same fascia iliaca covers the psoas major. It is now known as the psoas fascia. Psoas fascia. So, iliacus is covered by fascia iliaca. The same fascia iliaca now covers the psoas major. It is known as the psoas fascia. And as we go up, this fascia becomes thick here, thick. Extends from the body of L1 to its transverse process. Extends from the body of L1 to its transverse process. And this is what we call as the medial arcuate ligament. Medial arcuate ligament. So what is medial arcuate ligament? It's a thickening of the psoas fascia. Psoas fascia, thickening of psoas fascia, and this is the medial arcuate ligament. The fascia iliaca covers the iliacus. The same fascia iliaca covers the psoas major, and as we go up, this fascia becomes thick, extends from the body of L1 to its transverse process, and this is what we call as the medial arcuate ligament. Fine. Now, what is this muscle? Don't sit and type anything, just sit and listen. I won't be repeating it again and again. Just sit and listen. Who's asking about yesterday now? Just listen to what I'm telling you now. What is this muscle? This muscle is a quadrangular muscle of the lumbar region. Quadrangular muscle of the lumbar region, we call this as the quadratus lumborum. Quadratus lumborum. It begins from the iliac crest and it is attached to the 12th rib. And this quadrangular muscle of the lumbar region is known as quadratus lumborum. Now, this quadratus lumborum is covered by two fascias. One which covers it from front. What is this fascia known as? This is known as the thoracolumbar fascia. Thoracolumbar fascia. The one which covers the quadratus lumborum from front, this is known as anterior layer of thoracolumbar fascia, and the one which covers it from behind, the quadratus lumborum from behind, is known as middle layer of thoracolumbar fascia. Middle layer. So one is the anterior layer, and the one which covers it from behind is known as the middle layer of thoracolumbar fascia. Now, this anterior layer of thoracolumbar fascia, as we go up, it becomes thick here, thick. Extends from the transverse process of L1 to the 12th rib. Look, extends from the transverse process of L1 to the 12th rib, and this is what we call as the lateral arcuate ligament. Lateral arcuate ligament. So what is lateral arcuate ligament? It's the thickening of the anterior layer of thoracolumbar fascia. Okay, thickening of the anterior layer of thoracolumbar fascia. Now, why is this so important? Why are we discussing this early morning? The medial arcuate ligament, the lateral arcuate ligament, all this gives origin to what? Diaphragm. Diaphragm. Okay. So I'm starting with the diaphragm. Just have a look. Understand this. Now, don't write anything. Just listen. I'll be writing all this. I'll be repeating this again. Listen. Diaphragm has got three sets of origin. One is anteriorly. What is that? Sternal head. Second, from the sides, costal head, and the third one is vertebral head. So there are three heads of origin of diaphragm: sternal, costal, and vertebral. The sternal head begins from where? Xiphoid process. Sternal head begins from the xiphoid process. The costal head arises from the inner aspect of the lower six ribs. Inside, inner aspect of the lower six ribs. And the vertebral head arises from the medial arcuate ligament, the lateral arcuate ligament, plus the diaphragm also arises from the bodies of the lumbar vertebrae. Just have a look at this. What do you call this part of the diaphragm which arises from the bodies of the lumbar vertebrae as? This is what we call as the crus of the diaphragm. Crus. Understand now, this right crus is longer and stronger. The right crus is longer and stronger, arises from the bodies of L1 and L1, 2 and 3 lumbar vertebrae. That's the right crus. The left crus is small, arises from the bodies of L1 and L2 vertebrae. Okay, so now why is this right crust longer and stronger? Because when the diaphragm contracts, it goes down. It goes down. You know which diameter of the thorax is changed? The vertical diameter of the thorax. So when it goes down, it has to push the lever down on the right side. It has to push the lever down, and that's how the right crust of diaphragm is longer and stronger. So just to summarize, diaphragm has got three sets of origin. One anteriorly, sternal, second on the sides, costal, and the third one is behind, that's vertebral. The sternal head arises from xiphoid process. The costal head arises from the inner aspect of the lower six ribs, from inside, inner aspect of the lower six ribs. And the vertebral head arises from the right and the left crust, the medial and the lateral arcuate ligament. You are able to follow this? Now, where is the insertion of the diaphragm? All this, the sternal head will come from front, it will come back side. The costal head from the side, it will come in the center, and the vertebral head will come in front, and here it interdigitates like this to form what you call this as the central tendon of the diaphragm. This is what we call as the central tendon of the diaphragm, central tendon. Then you have to know what are the openings in the diaphragm. Openings. Okay, openings in the diaphragm. One, T8. Just wait, don't write anything. T8. T8 is IVC and the right phrenic nerve. Openings in the diaphragm. When we're writing all this, just listen. The first opening is at T8, IVC and the right phrenic nerve. T10 is the esophagus with the right and the left pancreas. And T12 is aorta, azygous vein, and thoracic duct. Clear to all of you? So that's about the diaphragm. We'll start with this. As you are writing, understand as you are writing. Starting with the diaphragm. A very important MCQ, diaphragm. Origin. It has got three heads of origin. Sternal, costal, vertebral. Sternal, costal, vertebral. Sternal, xiphoid process. Sternal arises from xiphoid process. Costal, inner aspect of lower six ribs. Inner aspect of lower six ribs. And vertebral head arises from as right and left crus. Vertebral head arises as the right and left crus. Second, medial arcuate ligament. Medial arcuate ligament, that's a thickening of psoas fascia. Thickening of the psoas fascia. And third is lateral arcuate ligament. Lateral arcuate ligament, that's a thickening of anterior layer of the anterior layer of thoracolumbar fascia. Thickening of the anterior layer of thoracolumbar fascia. You're clear with this, all of you? Origin is clear? Origin of diaphragm. Okay. Origin of diaphragm. Clear to all of you? Fine. Now starting with, if you're done, you tell me. Thoracolumbar fascia covers the quadratus lumborum. Okay, this I'll be repeating again and again. So by the time we close this topic, everything will be clear. Now these things are new for us. Done? Okay, fine. Insertion. Insertion is the central tendon. Insertion itself is known as central tendon. Next, openings. Openings in the diaphragm. 1. T8. T8 is IVC and the right phrenic nerve. IVC and the right phrenic nerve. IVC and the right phrenic nerve. The right phrenic nerve goes along with the IVC. Fine. Phrenic nerve. You can just quickly tell me phrenic nerve. Look, phrenic nerve. What is the root value of phrenic nerve? C3, C4, C5. C3, C4, C5. That's the main phrenic nerve. And sometimes you get an extra phrenic nerve. What you call this as accessory phrenic nerve. Okay. So accessory phrenic nerve arises from C5 root of the brachial plexus. C5 root of the brachial plexus. The main phrenic nerve is C3, 4, 5. Now, this phrenic nerve lies on what? You've seen this. The phrenic nerve lies on the scalenus anterior. Okay. Phrenic nerve lies on the scalenus anterior. Right phrenic nerve. Phrenic nerve lies on the scalenus anterior. Okay. Then this phrenic nerve enters the mediastinum. You've seen that. It enters the superior mediastinum. In which part? Middle compartment of the superior mediastinum along with vagus. The phrenic nerve now enters the inferior mediastinum. You know this also. In the middle compartment of the inferior mediastinum, it goes in front of the hilum of the lungs, right? Remember, nerve in front of the hilum was phrenic and nerve behind the hilum was vagus. Now, this phrenic nerve pierces the diaphragm. Okay, the right phrenic nerve, how does it enter the abdomen? It passes to the IVC opening. The right, remember it like this, veins are on the right side. So, IVC will be on the right side. So, which phrenic nerve will go with IVC? Right phrenic nerve. That's how you remember. The left phrenic nerve directly pierces the diaphragm. It pierces the diaphragm and goes in the abdomen. And the phrenic nerve supplies the diaphragm from the abdominal aspect. Okay. So, it supplies the diaphragm from the abdominal aspect. So, that's the entire phrenic nerve for you. Clear to all of you? Right. Very good. Right. So, openings in the T8 is IVC and the right phrenic nerve. T10 is esophagus. Esophagus with right and left vagus. Right and left vagus. Okay, quickly just tell me. Listen here now. This is clear now? Quickly tell me vagus once again. Vagus. Now, look, I'll just quick go through this. Vagus. I've told you this yesterday, but again I'm telling you. Vagus. Now tell me, what is the vagus supply? Vagus. Vagus is a nerve which pharyngeal arch. 4th and 6th pharyngeal arch. Okay. So vagus supplies the muscles of the pharyngeal arch. What is the name of the component to supply the muscles of the pharyngeal arches? Just listen. Special visceral efferent. And which is that nucleus of vagus belonging to this component? Nucleus ambiguous. But remember, the cranial accessory goes with the vagus. So we take the cranial accessory into this. What else is the vagus supply? The glands of GIT. Glands of GIT. So what is the name of the component for this? General visceral efferent. And what is the nucleus for this component? Dorsal nucleus of vagus. Following? What else is the vagus supply? The tongue. It supplies the posterior most part of the tongue. That is purely supplied by vagus. And this component to supply the tongue is a special visceral afferent. And the nucleus is the nucleus of tractus solitarius. You're getting this? So what are the nucleus of vagus? One is the dorsal nucleus of vagus. Second is the nucleus ambiguous. And the third one is the nucleus of tractus solitarius. Now, this vagus arises as rootlets. From this from this nucleus, some rootlets will come from here, some from here, some from here. And where is the vagus attached to the brainstem? You remember that slide of brainstem, midbrain, pons, medulla? You remember the nerves arising from the brainstem? So, this vagus is attached to the medulla between what and what? You remember the 9th, 10th and 11th cranial nerves? They are present between the olives and the inferior cerebellar peduncle. Okay, between the olives and the inferior cerebellar peduncle, 9th, 10th and cranial accessory was there. Now this vagus leaves the skull through which foramen? Jugular foramen. Which compartment? Middle compartment of jugular foramen. Now you understanding? So it leaves the skull through the middle compartment of the jugular foramen, and the moment it gets outside the skull, it's right inside the carotid sheath. This you know. The vagus runs through the carotid sheath, now comes to the thorax, enters the superior mediastinum, you know this, enters the inferior mediastinum, goes behind the hilum of the lung, enters the abdomen through the esophageal opening of diaphragm, and the vagus is now in the abdomen. The vagus in the abdomen supplies the foregut and the mid-gut. That's the end of vagus. Understood this? So that's how the vagus is going to supply. It's the longest cranial nerve, vagus. Where does the midgut? This I'll tell you later. Midgut, foregut, and all I'll tell you later. Fine. So esophagus with the right and the left vagus. So this is how you should be able to correlate things. Huh? Just don't keep upper limb as upper limb, lower limb as lower limb, thorax as thorax. It's not like this. Everything is correlated. If you understand it like this, it will be very interesting. Fine. And the next T12 is aorta, azygous vein, and thoracic duct. Aorta, azygous vein, and thoracic duct. Clear to all of you? So these are the openings in the diaphragm. Next, the sympathetic chain. Next MCQ. These are all very important small MCQs. The sympathetic chain enters the abdomen. Sympathetic chain enters the abdomen behind, just write this down, I'll show you the slide. Behind the medial arcuate ligament. The sympathetic chain enters the abdomen behind the medial arcuate ligament. The subcostal nerve and vessels enters behind, just write this down, I have to show you the slides, enters behind lateral arcuate ligament. The subcostal nerves and vessels enters behind the lateral arcuate ligament. Now what is this medial arcuate ligament? What is this lateral arcuate ligament? I'll tell you. Sorry that you're able to see this, no? Left phrenic, right phrenic, nowhere. Esophageal openings T8 is IBC and the right phrenic. How left phrenic? It's right phrenic. I've written left or what? Just one moment. I've written right phrenic now. One moment, I'll take that down. T8 is IBC and the right phrenic nerve. T10 is esophagus with the right and left vagus, and T12 is aorta, azygous vein, thoracic duct. Okay. The sympathetic chain enters the abdomen behind the medial arcuate ligament, and the subcostal nerve and vessels enters the abdomen behind the lateral arcuate ligament. Okay, when I'm explaining, just listen to what I'm explaining. Don't sit and write when I'm talking to you. Okay, listen to this, then it will be easy to understand. Okay, have a look at this. Look at this slide. Okay, look at this slide. I'll start once again. Tell me now, what is this here? What is this? This is the medial arcuate ligament. What is this here? This is the lateral arcuate ligament. And what would this be here? This would be the crus of the diaphragm. Which crus is this? Right crus. And on this side would be the left crus, the medial and the lateral arcuate ligament. Okay. Now, what enters the abdomen behind the medial arcuate ligament? Look at that. The sympathetic chain. And what enters the abdomen behind the lateral arcuate ligament? That's the subcostal nerve and vessels. You remember subcostal nerve? Subcostal, this is what I was telling you. How many intercostal nerves are there? How many ribs are there? 12. So how many spaces are there? 11. 11 spaces behind. Okay, 11 spaces behind. 11 posterior intercostal spaces. So how many posterior intercostal nerve and vessels would be there? 11. But there's a nerve and artery below the 12th rib, and now we do not call it as intercostal because there's no rib below it. We call this as the subcostal nerve and vessels. Okay, and this subcostal nerve and vessels enters the abdomen behind the lateral arcuate ligament. Lateral arcuate ligament. Okay, the subcostal nerve and vessels, I had written that if it's not clear, the subcostal nerves and vessels enters behind the lateral arcuate ligament. Is this clear to all of you? Yes, clear to all of you. The diaphragm is extremely important MCQ. And now if you can tell me, look, the development of diaphragm. Once again, quickly I'll just go through it. Development of diaphragm. The main contribution to the formation of diaphragm was what? Septum transversum. Second is the pleuroperitoneal membranes. Third is the dorsal mesentery of the esophagus. And the fourth one, the peripheral part is formed by the body wall. Clear? So one is septum transversum, second is the dorsal mesentery of the esophagus, third is the pleuroperitoneal membranes, and fourth is the body wall. This is going to form the structure of the diaphragm. Structure. The muscles of the diaphragm are derived from the neck. What is that known as? Cervical myotomes. Muscles are derived from the neck. Cervical myotomes. Is this clear? And that's how the phrenic nerve from the neck comes down to supply the diaphragm, because the muscles are derived from the cervical myotomes. This is exactly very similar to something. Structure is formed somewhere else and the muscles are derived from somewhere else. This is exactly similar to the development of tongue. You remember the structure of the tongue is formed in the pharyngeal arches. Pharyngeal arches. You remember the anterior 2/3 is derived from two lingual swellings and tuberculum impar. That's the first arch. Nothing in the second arch. In the third and the fourth arch, you get this hypobranchial eminence or cupula. I've told you this yesterday. So the tongue is formed in the pharyngeal arches, and the muscles of the tongue are derived from occipital myotomes. Occipital myotomes. And that's how the hypoglossal nerve is motor to the tongue. Motor supply is hypoglossal nerve, and the arch in which the tongue develops, that becomes the sensory nerve supply of the tongue. Following this? Now, this extraocular, the tongue muscles are derived from what? Occipital myotomes. Which other muscles are derived from occipital myotomes? Extraocular muscle. Extraocular muscle and tongue muscles are derived from occipital myotomes. And what is the name of the component which supplies the muscles derived from occipital myotomes? General somatic efferent. General somatic efferent. Okay. So anywhere you start now, you can just go and revise everything. It's like that. Only thing you should be able to correlate that. Clear to all of you following this? Okay. So that's about the diaphragm. Look, this is a beautiful slide. This is a very important slide. Plenty of slides in the abdomen. Plenty. Understand? So I'll keep on giving references like this. Your job is just to listen to me. The more you put your concentration into, the more you'll understand the subject. Okay, do not sit and write, do not sit and chat when I'm talking, because I tell many things, because now you are aware of so many things. I'll just try to give you correlations wherever I can. Okay, just be with me. Fine, that's it. Okay, so now starting with the abdomen. Starting with the abdomen now. So I just told you the diaphragm, starting with the abdomen. Now we start with the posterior abdominal wall. Look, how will we be finishing the abdomen? We first start with the posterior abdominal wall. We see the muscles on the posterior abdominal wall. We put a plexus on the posterior abdominal wall. That's the lumbar plexus. We see the blood vessels on the posterior abdominal wall. So that would complete my posterior wall. Then we go to the anterior abdominal wall. We see the inguinal canal there. Then we enter inside the abdomen. First we study the peritoneal reflections inside the abdomen, and then we go to the organs. We study some important organs. We study the embryology of those important organs. So that completes the abdomen. Then we go down into the pelvis. We see the organs in the pelvis. We see the embryology of the organs in the pelvis. That will complete the pelvis, and further down we go below the pelvis. Where are we? we are not out of the pelvis, we are into the perineum, the last part. Okay, so abdomen is a pretty big topic. It's a very big topic. Just concentrate, and it is very nice to understand. Only thing is, it is slightly difficult because of plenty of relations, but that's a joy to understand the relations. Okay. Okay, starting now with the posterior abdominal wall, and the posterior abdominal wall is formed by one. Here we are. That's the psoas major muscle, psoas major, and occasionally, sometimes you see this muscle here. What is this muscle? A muscle very similar to psoas major, a muscle which begins from the transverse processes of the lumbar vertebrae and goes down, inserts on the femur. And this is the psoas minor. Psoas minor. Okay, very rarely seen, but it may be present. I'll tell you that phrenic now. Don't keep on asking things again and again. I'll be telling you again somewhere. Okay, so that's psoas minor, that's psoas major. Psoas minor is rarely seen. What is this quadrangular muscle here? This is the quadratus lumborum. Okay. Now, what is the psoas major covered by? Psoas fascia. And what is this known as? The medial arcuate ligament. What is the quadratus lumborum covered by? The thoracolumbar fascia. The one which covers it from front is known as anterior layer, and this anterior layer becomes thick. What is this known as? Lateral arcuate ligament. This is all you know. Now, at the which is this muscle? Lateral muscle. This is the transverse abdominis. So now three muscles we have here. One, psoas major, quadratus lumborum, and transverse abdominis. These three muscles are going to form what? The posterior abdominal wall. Clear? So posterior abdominal wall is formed by psoas major, quadratus lumborum, and transverse abdominis. Starting with this posterior abdominal wall. Posterior abdominal wall formed by psoas major, quadratus lumborum, and third is transverse abdominis. Okay. Psoas major, quadratus lumborum, and transverse abdominis. Psoas major, quadratus lumborum, and transverse abdominis. Clear to all of you? Now, we put the plexus on the posterior abdominal wall. Understand this now. These things are very important. I'll start. What is the plexus on the posterior abdominal wall? The lumbar plexus. Starting with the lumbar plexus, have a look. Understand this first. Quadratus lumborum. Okay, in that diaphragm, that small point was left. Now look here, one moment. Listen here. You know, this, the sternal origin of diaphragm. Listen here. The sternal origin of diaphragm arises from where? Xiphoid process. And the costal origin arises from where? The ribs. This I told you. Sternal origin is from the costal process. The costal origin is from the ribs. Sternal origin is from the xiphoid process, and the costal origin is from the ribs. And between these two processes, there's a small gap left. That is known as the sinus of Morgagni. Or space of Larry. That's in the diaphragm. There's a small gap between the sternal origin and the costal origin of diaphragm, and that gap is known as the foramen of Morgagni. And what passes to the foramen of Morgagni, if you remember? The superior epigastric vessels. Remember that? The superior epigastric artery and vein. And this superior epigastric artery is going to anastomose with the inferior epigastric artery, which is a branch of external iliac. This I've told you. So that was sinus of Morgagni, or foramen of Morgagni in the diaphragm. If you want, you can just write it down in the diaphragm. Foramen of Morgagni. I just missed that. Foramen of Morgagni. If there's a space, let's just write down. Foramen of Morgagni. It is also known as the space of Larry. Foramen of Morgagni, or the space of Larry. A small defect between a small defect between sternal and the costal origins, sternal and the costal origins, the superior epigastric vessels enters the abdomen through this gap. Superior epigastric vessels enters the abdomen through this gap. Posterior abdominal wall is formed by three muscles: psoas major, quadratus lumborum, transverse abdominis. Okay, clear to all of you? That's about the diaphragm. And then I told you what is Bobelix hernia and all. Okay. Clear? So posterior abdominal wall, I told you, is formed by three muscles: psoas major, quadratus lumborum, transverse abdominis. Fine. Now starting with the lumbar plexus. Understand this. Be faster. Abdomen is a big topic. You're done with the writing now. Lumbar plexus. Now once again tell me, what is a plexus? What is a plexus? This I've told you many times. Plexus is a group of nerves, or it's a network of nerves. Plexus is a group of nerves, or plexus is a network of nerves. And how is a plexus formed? A plexus is formed by the ventral ramus of the corresponding spinal nerve. I told you this. Plexus is formed by the ventral ramus of the corresponding spinal nerve. In thorax, there is no plexus. Thorax, there is no plexus. So what happens to the ventral ramus of a thoracic spinal nerve? In the thorax, there is no plexus. So what happens to the ventral ramus of a thoracic spinal nerve? This ventral ramus runs in the intercostal space. The ventral ramus runs in the intercostal space, and this is what we call as an intercostal nerve. Clear? So in the thorax, no plexus. So the ventral ramus runs in the intercostal space, which we now call as the intercostal nerve. So how will the lumbar plexus be formed? It will be formed by the ventral rami of lumbar spinal nerves. Ventral rami of the lumbar spinal nerves. Now I'll start with this. A small contribution from T12 is there. T12, L1, L2, L3, L4. Don't draw this out. This is difficult. I'm telling you, just listen to this first. Do not draw anything. So normally lumbar plexus is formed from L1 to L5, but some books mention T12. I give you T12 also in this. Okay, then you have to see the options and accordingly you have to answer. I'll tell you. Now, right at the outset, don't draw. I'll give you time for this. Just wait. Right at the outset, the ventral ramus of L4 divides into two ventral rami. Look, normally a ventral ramus divides into what? Normally a ventral ramus divides into a dorsal division and a ventral division. You remember? Normally a ventral ramus divides into a dorsal and ventral divisions. In this case, the ventral ramus of L4 itself divides into two ventral rami. L4 is therefore known as the nervus furcalis. Nervus furcalis. Nervus furcalis is the ventral ramus of L4. Don't write this. Just wait. Why is it no? See, you will tell me then in the brachial plexus also there is a dorsal and ventral ramus, no? Okay, in two ramus it divides. But in this case, it divides into divisions, dorsal and ventral divisions. But in this case, the ventral ramus of L4 itself divides into two ventral rami. This is also ventral ramus, this is also ventral ramus. And that is why the ventral ramus of L4 bifurcates into two. L4 is therefore known as nervus furcalis. Nervus furcalis. Okay, I'm starting here. Listen here now. A part of L4 joins with L5. A part of L4 joins with L5. Now this is a trunk, and this trunk is formed in the lumbar region. Okay, and from the lumbar region we are going down. Where are we? Into the pelvis. From the lumbar region we come down, we come on either sides of the sacrum in the pelvis. Now this is a trunk, begins in the lumbar region and goes to the sacral region, and this is what we call as the lumbosacral trunk. Lumbosacral trunk. Give me a reference now. I've told you this somewhere. Lumbosacral trunk. If you can just give me a reference. Yes. Somewhere I've told you this lumbosacral trunk. Remember this mnemonic I told you. SLIO. You remember what was SLIO? These are the relations of the ala of sacrum. Very good. Relations of the ala of sacrum. What is the body of S1 known as? Body of S1 is known as what? Sacral promontory. Body of S1 is sacral promontory. The two wings are known as what? Ala of the sacrum. Ala. So this is the ala of the sacrum. Relation is L is lumbosacral trunk. Okay, then S was what? Sympathetic chain. L is lumbosacral trunk. I is an artery. What's that? Iliolumbar artery. And O is the obturator nerve. Obturator nerve. We'll see this later. So L is lumbosacral trunk. Now this lumbosacral trunk enters the pelvis. It will join with the ventral ramus of S1 to S5 and now form a plexus here. What is this plexus known as? Sacral plexus. You understanding how the sacral plexus is formed? A part of L4 joins with L5. A part of L4 joins with L5, and this is what we call as the lumbosacral trunk. Lumbosacral trunk. This lumbosacral trunk enters the pelvis, joins with the ventral rami of S1 to S5, and that is what forms the sacral plexus. Okay, so sacral plexus is formed from S1 to S5 in addition L4, L5. You understanding? See, for example, sciatic nerve. You know sciatic nerve, sciatic nerve. Sciatic nerve is a branch of what? Sacral plexus. But you know what is the root value of sciatic nerve? L4, 5, S1, 2, 3. Now when sciatic nerve is a branch of sacral plexus, how does this L4, L5 come into this? That means this L4, L5 from the lumbar region enters the pelvis, joins with the ventral ramus of S1 to S5, and this is what is going to form the sacral plexus. You're following this, how the sacral plexus is formed? That means L4 forms two plexus. This will take part in the formation of lumbar plexus, and this will take part in the formation of sacral plexus. The ventral ramus of L4 is therefore known as the nervus furcalis. Am I clear to all of you? Just draw this much. Draw this much. I'll give you time to draw in between. Okay, don't sit and draw. Concentrate. Otherwise, when you draw, you don't listen. Okay, if you're done, you tell me. This is the lumbosacral trunk. Lumbosacral trunk. Understand, listen, now we are entering into the abdomen from the posterior abdominal wall, slowly. And as we build the abdomen, you'll understand it. Okay, done. Very good. Now start. Have a look. Now T12. See, again I'm telling you, some books will mention T12, some do not. I always give you T12 in the options. We don't know how the options will be there in the MCQ. Okay, so I consider everything and tell you. I'll start. Look, this is so nice. Just listen, do not drop. T12 joins with L1. Here we are. T12 joins with L1, divides into two. The upper one further divides into an iliohypogastric and ilioinguinal nerve. Iliohypogastric and ilioinguinal nerve. Look here once again. T12 joins with L1. Here it joins, divides into two. The upper one further divides into iliohypogastric and ilioinguinal nerve. You following this? Now this lower one joins with a direct branch from L2. Just one moment. This lower one joins with a direct branch coming from L2. It comes from L2, and this is what we call as the genitofemoral nerve. Genitofemoral nerve. That's the genitofemoral nerve. So if I'm asking you, what is the root value of iliohypogastric and ilioinguinal nerve? Okay, what is the root value of iliohypogastric and ilioinguinal? This would be T12 L1. But again I'm telling you, if T12 is not in the option, answer this as L1 then the option would be given as L1. But sometimes the option may be given as T12 and L1, so then you will be confused. That is why I'm telling you like this. You're following now? Okay, what is the root value of genitofemoral nerve? Ideally, the books will mention you as L1 and L2, but take T12 also. So it's T12, L1, L2. T12, L1, L2. Clear? A small contribution of T12 in the formation of lumbar plexus. So look here once again, T12 joins with L1, divides into two. The upper one further divides into an iliohypogastric, ilioinguinal. The lower one joins with a direct branch from L2 and forms the genitofemoral nerve. Just draw this much. Okay, now after this, done. After this, see this now. After this, now L2 just gives a branch to form the genitofemoral nerve, direct branch from L2 to form the genitofemoral nerve. After this, L2, L3, L4 divides into a dorsal, dorsal, dorsal and a ventral, ventral and ventral divisions. Following? L2, L3, L4 divides into a dorsal and ventral divisions. I'll make it like this. I'll make dorsal in blue, dorsal and ventral divisions. Clear? Now, dorsal division of what divides again? What divides into dorsal ventral division? The ventral ramus. Look, this is the ventral ramus. Don't forget that. The ventral ramus now divides into a dorsal ventral division. Now, the dorsal division of L2 and L3 forms, this is the lateral femoral cutaneous nerve of thigh. Lateral femoral cutaneous nerve of thigh. Lateral femoral cutaneous nerve of thigh. What will the root value be? L2, L3. Lateral femoral cutaneous nerve of thigh. Again, just wait. Again, I have to take the dorsal division of L2. I take it from here. The dorsal division of L2, dorsal division of L3, and this time the dorsal division of L4. And what's this? Femoral nerve. Femoral nerve. So what is the root value of femoral nerve? L2, L3, L4. Okay, this is slightly difficult to understand. Just draw this. If you don't understand, you tell me. Look here, once again I'll draw. Once again I'll draw for you. Just have a look. Listen here, one moment. Okay, tell me. L2 first gives a direct branch to form the genitofemoral. Okay, L2 first gives a direct branch to form the genitofemoral. Now, the ventral ramus of L2, this ventral ramus of L2, ventral ramus of L3 and ventral ramus of L4 divides into, this will divide into a dorsal and a ventral division. Dorsal ventral, dorsal ventral, dorsal ventral division. The dorsal division of L2 and L3 forms what? Lateral femoral cutaneous nerve of thigh. Again, the dorsal division of L2, L3 and this time is L4. What's that? Femoral nerve. So ideally, what is the root value of femoral nerve? It is formed by the dorsal divisions of the ventral rami of L2, L3, L4. Don't draw this, just wait. And now what are we left with? Now what are we left with? Ventral divisions. We just left with ventral divisions. Okay. And what will this ventral division form? The ventral division of ventral rim of L2, L3 and L4 will form what? Obturator. Obturator. Understood? Fine. Just do one thing. Draw this much now. Make this like this. Make like this. Dorsal ventral divisions you make. First make this dorsal ventral divisions. L2, L3, L4 divides into iliohypogastric. The first one is iliohypogastric. Iliohypogastric and ilioinguinal. Okay, so L2, L3, L4 divides into a dorsal and ventral divisions. Now join this dorsal division of L2 and L3. L2, L3. Dorsal division of L2, L3 forms the lateral femoral cutaneous nerve of thigh. Again you take dorsal division of L2, L3 and this time L4. L2, L3, L4. That's femoral nerve. Dorsal division of L2, L3, L4 is femoral. And now join this ventral division of L2, L3 and L4. What's that? Obturator. Ventral division of L2, L3, L4 is obturator nerve. It is tough. I told you, no. See, why I tell you things are difficult, because you need to pay more attention. Nothing to scare you, but you will understand. Now see, quickly I'll tell you this. Things may be difficult, but they are not impossible. Remember, you can always overcome them. Okay, clear? Now see. Listen, once again I'll quickly go through this. Look, it is very easy. Only thing is that initially you might find it slightly difficult, but the more you revise it, the more easy it is going to be. I'll start. Have a look here once again. Now see, understand like this. This is T12, L1, L2, L3, L4 and L5. These are the ventral rami. Right at the outset, the ventral ramus of L4 divides into two. L4 is known as nervus percalis. A part of L4 joins with L5, what's this? Lumbosacral trunk. Enters the pelvis, joins with S1 to S5 and forms what? Sacral plexus. That's sacral plexus. Okay. Now we start. T12 joins with L1 here, divides into two. The upper one further divides into an iliohypogastric and ilioinguinal nerve. The lower one joins with a direct branch from L2 and forms what? What is that? Genitofemoral nerve. After this, L2, 3, 4 divides into a dorsal division. Ventral I'll draw later. Dorsal division of L2, L3 forms lateral femoral cutaneous nerve thigh. Again, the dorsal division of L2, L3 and this time L4, that's femoral nerve. And now we are left with the ventral divisions of L2, 3, 4. If we join this, that's obturator. It's easy. Okay, understood now? So that's the lumbar plexus. Some MCQs now on the lumbar plexus. So just tell me one thing. What is the root value of femoral? See, femoral, obturator, all this will be doing in the lower limb. But I'm just starting with this. So when we come to the lower limb, you know everything about it. So what is the root value of femoral now? It is formed by, basically the same, L2, L3, L4. For both femoral and obturator nerve, it's L2, L3, L4. Something's second common thing is it's ventral ramus. Ventral ramus is common for both of them. Only one difference. Femoral nerve is formed by dorsal division of ventral rami of L2, L3, L4. Obturator nerve is formed by ventral divisions of ventral rami of L2, L3, L4. That's the only difference. Is this clear to all of you? Femoral nerve is dorsal division, obturator nerve is ventral division. Yes, ventral division of T12, L1, L2, that is okay. Genitofemoral nerve is T12, L1, L2. Clear some MCQs on lumbar plexus. Very good. You've understood, no? Nervus percalis is ventral ramus of L4. Ventral ramus of L4. Nervus percalis is ventral ramus of L4. L4 forms lumbar and sacral plexus. Lumbar and sacral plexus. L5 forms only lumbar plexus. L5 forms only lumbar plexus. Okay. Next, nerve lying on psoas major. Nerve lying on psoas major, genitofemoral nerve. Nerve lying on the psoas major is genitofemoral. Neuralgia. Neuralgia paresthetica. Just write it down. I'll explain this later. I'll show you the slide. Just write this down. Neuralgia paresthetica is the compression of lateral femoral cutaneous nerve of thigh. Lateral femoral cutaneous nerve of thigh against inguinal ligament. So compression of lateral femoral cutaneous nerve of the thigh. This lateral femoral cutaneous nerve of thigh is a branch of lumbar plexus, and this gets compressed against the inguinal ligament. This I'll tell you in lower limb, and this is what we call as meralgia paresthetica. Meralgia paresthetica is a compression of the lateral femoral cutaneous nerve of thigh against the inguinal ligament. Okay. Clear to all of you? So that's about the lumbar plexus. L5 forms only sacral plexus. Yes, L5 forms only L5 forms sacral plexus. L4 forms lumbar and sacral plexus. Sorry for that. L5 forms only sacral plexus. Yes. You understood, no? It's a slip of tongue. L and hand. L5 forms only sacral plexus. Okay. Fine. Nerve lying on the psoas major, genitofemoral. Meralgia paresthetica. Okay, so this is everything about lumbar plexus. Now see the slide, abdomen and head and neck. Plenty of visual slides, plenty. So be clear with your concepts. Again, I'm telling you, if you're clear with your concepts, slides will be very easy to understand. Then the more you see the slides, the more you'll be able to revise topics. Clear, no? Lumbosacral plexus also you call it as, that's fine. Lumbosacral plexus, we call it as sacral plexus. Lumbar plexus is found in the lumbar region. We are studying the lumbar region, we are in the abdomen now. L5 forms the sacral plexus. Clear? Nervus furcalis is the ventral ramus of L4. Nervus furcalis is ventral ramus of L4. Clear to all of you? Now see the slide and just try to understand this. Okay, look at this now. Look, this is a very good slide. Try to understand this. I'll start. Be very clear about this slide. I'll start. Have a look. I'll show you all the slides. I'll show you all the diagram. Have patience. I'll start. Chalo. What is this nerve? This, you know, this is the subcostal nerve. This nerve is the subcostal nerve. That's a subcostal nerve. What is this nerve? This is the iliohypogastric. What is this nerve? This is the ilioinguinal. Iliohypogastric, ilioinguinal. And this is a branch of lumbar plexus. It comes out at the most lateral aspect of the inguinal ligament, the most lateral aspect of the inguinal ligament, and this nerve gets compressed against the inguinal ligament. What does the person complain of? Paresthesia, tingling and numbness. Paresthesia, tingling and numbness along the lateral aspect of the thigh, and this is what we call as meralgia paresthetica. Meralgia paresthetica. So meralgia paresthetica is a compression of lateral femoral cutaneous nerve thigh, which is a branch of lumbar plexus. Remember, I'm very specific in telling you this, okay? Against the inguinal ligament. Okay, this is the nerve lying on the psoas major, and that's the genitofemoral nerve. And there's someone hiding here. Look, there's someone hiding here. What is this muscle? Iliacus. What is this muscle? Psoas major. What do you call this groove as? Iliopsoas groove. Iliopsoas groove. And the nerve lying in the iliopsoas groove is femoral nerve. Femoral nerve. Okay, just add that. Nerve lying in iliopsoas groove. Nerve lying in iliopsoas groove. Nerve lying in the iliopsoas groove is femoral. Femoral. Nerve lying in the iliopsoas groove is femoral nerve. Clear to all of you, following this now? Nerve lying in the iliopsoas groove is femoral. Okay, fine. Okay, once again, and there will be one more nerve, obturator nerve. You can't see the obturator nerve because this will be behind the vessels. It's behind the vessels. So if you remove this vessels, behind them is going to be what? Obturator nerve. You can't see that. Okay, clear with the slide? Once again, have a look at this complete slide now. Now you know the slide. I'll start. Have a look. Start. What is this muscle? Psoas minor. What is this muscle? Psoas major. What's that? Quadratus lumborum. What's this? Transverse abdominis. What is this? Medial arcuate ligament. This lateral arcuate ligament. What's this? The crus of the diaphragm. Okay. Now what is this chain? The sympathetic chain. And what's this? The subcostal nerve and vessels. Subcostal nerve and vessels. This is the subcostal nerve here. This is the iliohypogastric nerve, ilioinguinal nerve, the lateral femoral cutaneous nerve thigh, the femoral, the genitofemoral nerve, and there'll be a nerve deep to this, below the vessels, that is the obturator nerve. Am I very clear with lumbar plexus now? Dorsal division ही है ना, dorsal division. We'll be studying all femoral obturator nerve tomorrow. Whenever we are discussing the lower limb. Okay, clear to all of you. This slide is very important. The posterior abdominal wall. So what are we discussing now? The posterior abdominal wall. One, I've told you the muscles on the posterior abdominal wall. Second, I've told the plexus on the posterior abdominal wall. And we start with the blood vessels on the posterior abdominal wall. Blood vessels. Starting with abdominal aorta and its branches. Blood vessels on the posterior abdominal wall. See to it that you understand everything, huh? And things which are important, I'll go slow, you'll understand. Abdominal aorta and its branches. We'll see this again. Later now we'll be again seeing this. And look, you know, we just put an organ here. Just one moment. You just put an organ here. Look, this is nice. Just place an organ here. And what is this organ? Sorry, what is that? What am I wanting to draw here? That's a kidney. Just place a kidney here. And all this will become what for the kidney? All this will become what for the kidney? This will become the posterior relations of the kidney. Posterior relations of the kidney. Okay. So what are the posterior relations of kidney? See, abdomen, no, I'm telling you, if you understand one thing, you understand 3-4 things simultaneously. Because everyone is so close to each other. If one is like this, the other one is like this, the third one is like this. So they are very close. Each one of them is related to each other. You understand one thing very well, you understand, then automatically you understand 3-4 more things simultaneously. So what are the posterior relations of the kidney? The first muscle, psoas major. The second muscle, quadratus lumborum. The third muscle, transverse abdominis. The medial and the lateral arcuate ligaments. And 3 nerves, the subcostal, the iliohypogastric and the ilioinguinal nerves. This becomes the relations of the kidney. Understood? All this will be studying later. All this I'll be telling you later. So you get MCQs on this. While exposing the kidney from a posterior aspect, all the following structures will be encountered except. Understand? Okay, that's it. Starting with abdominal aorta and its branches. Abdominal aorta and its branches. Abdominal aorta and its branches. Start with this. Just remember this mnemonic: 2, 3, 4 and 5. That's the easiest way to understand abdominal aorta. 2, 3, 4, 5. Start with this. 2. Terminal branches. Write this down first. Understand this first, and then you see the slides. It should be perfect. 2 terminal branches. And tell me, where does the aorta divide? Aorta divides at L4. And where is the IBC formed? IBC is formed at L5. Remember, aorta bifurcates at L4, IBC is formed at L5. So two terminal branches of L at L4, that is common iliacs. Common iliac. Three ventral branches. Three ventral branches. 1. Celiac trunk. Celiac trunk. What is the vertebral level of celiac trunk? T12. And what is it going to supply? The foregut. Foregut. It supplies the foregut. Now we have got three guts: foregut, midgut, hindgut. So there are three arteries for three gut. Celiac trunk vertebral level is T12, supplies foregut. Second, superior mesenteric artery. Superior mesenteric artery. Vertebral level L1, supplies the midgut. Vertebral level is L1, and what is it going to supply? Midgut. And the last one, inferior mesenteric. Inferior mesenteric artery. Vertebral level L3, and what does it supply? Hindgut. Supplies the hindgut. Okay. So these are the three ventral branches: celiac trunk, superior mesenteric, inferior mesenteric. Supplies the foregut, midgut, hindgut. Aorta divides at L4. IBC is formed at L5. Remember that, huh? Aorta bifurcates at L4. IBC is formed at L5 by the joining of two common iliacs. Clear? So celiac trunk, superior mesenteric, inferior mesenteric. And these are the vertebral levels. Just remember, all these vertebral levels are very important. Now coming down, the next, number 4. So 3 ventral branches is done. Now coming to 4. 4 lateral branches. 4 are lateral branches. And you know, these branches, lateral branches, will be in pairs. They are given in pairs like this. Tell me now, where are we now? We are in the abdomen. And we look up. Look, who's that up? You from the abdomen, be looking up. Who's that up? Diaphragm. And this artery goes and supplies the diaphragm from the inferior aspect. What is that? I told you the name. Inferior phrenic. This is the first branch. Inferior phrenic artery. Inferior phrenic artery. Second, middle suprarenal. This all you have to know. Middle suprarenal artery. Third, renal. And fourth, gonadal. Inferior phrenic, middle suprarenal, renal, and gonadal. I'll show you all the slides, but be perfect with the theory first. Inferior phrenic, middle suprarenal, renal, and gonadal. And 5 dorsal branches. This is the easiest way to understand the abdominal aorta. Okay, now tell me now, who's lying behind the aorta? Or the aorta is lying on what? Aorta is lying on what? Lumbar vertebrae. So aorta will supply the lumbar vertebrae. Simple. Aorta is lying on the lumbar vertebrae. So aorta is going to supply the lumbar vertebrae. How many lumbar vertebrae is the aorta going to supply? How many lumbar vertebrae do we have? 5. So aorta will supply 5 lumbar vertebrae? No. Aorta will not supply 5 because aorta doesn't reach till L5. You're following? Aorta divides at L4. So aorta will supply only 4 lumbar vertebrae. And this will be in pairs like this. We call this as 4 pairs of lumbar arteries. 4 pairs of lumbar arteries, and there's one artery which is left, median sacral artery. 4 pairs of lumbar arteries and 1 median sacral artery. Now who's left? 1 lumbar vertebrae is left, right? Who's left? L5. So 4 pairs of lumbar arteries and 1 median sacral artery. Done with this stuff? Who's left now? L5 is left. Now who's going to supply L5 vertebrae? L5. Aorta divides at L4. Now L5 is still left. Listen now. Aorta divides into two common iliacs. Aorta bifurcates into two common iliacs. There are no branches from the common iliacs. Common iliacs further divides into an external iliac and internal iliac. The external iliac goes down, and the moment it crosses the inguinal ligament, it continues as what? Femoral artery. We'll be seeing this in the lower limb. So external iliac becomes the femoral. And I told you one branch of external iliac, if you remember. I told you one branch of external iliac artery, if you remember. Just a cross reference I'm giving. Just a cross reference. What was that branch of external iliac? Inferior epigastric artery. Very good. Inferior epigastric artery is a branch of external iliac. Okay, no? Fine. Superior epigastric artery was a branch of internal thoracic artery. Superior epigastric is a branch of internal thoracic. Inferior epigastric is a branch of external iliac. Fine. I'm not going to that. Aorta divides into common iliacs. Common iliacs further divides into an external and internal iliac. The external iliac goes below the inguinal ligament and continues as what? Femoral artery. Now who's left? Internal iliac. And this internal iliac is the artery of the pelvis, and this internal iliac in the pelvis gives an artery, and this artery is going to ascend up, and as it is ascending up, it is related to the ilium. It is related to the ala of the sacrum, and this artery supplies the ilium and L5 vertebrae. Guess. Look, I've told you many things. Now you should be able to guess. Guess this artery. It begins from the pelvis, it ascends up, supplies the ilium and L5 vertebrae, and that's the iliolumbar artery. And as this artery is ascending up, it is related to the ala of sacrum. SLIO. That I is iliolumbar artery. Am I clear? Yes. So L5 is supplied by. Don't get confused now, because I try to tell many things. Don't get confused. L5 is supplied by iliolumbar artery. Just need to know this. Later we'll be discussing internal iliac and all. Okay, so L5 is supplied by iliolumbar artery, a branch of posterior division of internal iliac. So L5 is supplied by iliolumbar artery, a branch of posterior division of internal iliac. So look, I've told you something extra now. If you can understand, I've told you something extra now. First I told you iliolumbar artery is a branch of internal iliac. Now I've told you something specific. It's a branch of posterior division of internal iliac. That means, what am I telling you indirectly? The internal iliac divides into an anterior division and posterior division. Understand? That's how you built up your concepts. So the posterior division gives a branch, iliolumbar artery. All this will be studying in details in the pelvis. Right? So just a reference for you. Clear to all of you? Okay, clear all of you? Fine, I'm starting here. Have a look. Now, these are very important visual slides, so you should be perfect with this. What are these two? Common iliacs. These are the two common iliacs. So two terminal branches, three ventral branches. This is 1, this is 2, and this is 3. What's this? First one, coelentrum. Second is superior mesenteric. Third is inferior mesenteric. 4 lateral branches. This is 1. This is, look, this is going up to the diaphragm. So what's that? Inferior phrenic. This is the second one, going to the suprarenal gland. You know that's the suprarenal gland, so that's middle suprarenal. What's this here? Renal. And this is the gonadal artery, number 4. And this gonadal artery is crossing what? What is this gonadal artery going to cross? You can see this ureter. The gonadal artery is crossing the ureter. Look, one of the most important structure is ureter. And ureter is difficult. Why? You know, because it has got plenty of relation. It starts from the abdomen and goes into the pelvis. So it has got many relation. So wherever I see the ureter, slowly, I'll tell you something about the ureter. By the time I come to the topic as ureter, you know everything about it. So one anterior relation of ureter is going to be gonadal vessels, gonadal artery and vein. Clear? So look, 4 lateral branches. 1 inferior phrenic, 2nd middle suprarenal, 3rd renal, and 4th is gonadal. And now 5 dorsal branches. These are in pairs. That's the first pair. Look, first pair, second pair, third pair, and the 4th pair of lumbar arteries. 4th pair of lumbar. So 4 pairs of lumbar arteries, and this artery which runs in the midline of the sacrum. What's this? Median sacral artery. Median sacral. Superior mesenteric is L1. Okay. Is this clear to all of you? So that completes my blood vessels of the blood vessels of the gut. Clear? Okay, clear to all of you? Now we go into details of the celiac trunk, superior mesenteric, inferior mesenteric. Okay, these arteries are very important for you. Celiac trunk, its branches, superior mesenteric and inferior mesenteric. Okay, I'll start. Diagram I've just told you now. You'll see the slides later. You'll get all these things to understand. Okay, fine. Now, before I start with the celiac trunk, superior and inferior mesenteric, renal artery will be L2. L2. Okay. Now, understand this. Okay, I'll start. Now we'll start with celiac trunk, the superior and the inferior mesenteric artery. Before I start with this, tell me, celiac trunk supplies what? Foregut. Superior mesenteric supplies the midgut, and inferior mesenteric supplies the hindgut. Okay. Right. You'll understand all those iliolumbar artery and all. I've just given a reference right now. So foregut extends from where to where? Just tell me. Foregut extends from. You know that's a mouth, esophagus, stomach, then duodenum, the first part of the duodenum, and upper half of the second part of duodenum up to the opening of bile duct. So foregut extends from, just listen, don't write anything. Foregut extends from mouth, your esophagus, stomach, the first part, and the upper half of the second part of duodenum up to the opening of bile duct. The foregut also includes the liver, the pancreas, and the spleen. All this is what? Foregut. Which is the artery of foregut? Celiac trunk. The midgut begins from the lower half of second part of duodenum, the third part of duodenum, the fourth part of duodenum. Duodenum is over. After the duodenum, what do you have? Jejunum. After the jejunum, what do you have? Ileum. Ileum comes and joins what? Cecum. There's a small appendix here, and this is going to ascend up. What's that? Ascending colon. And what's this bend known as? This bend, there's a lever here, lever. So that's the hepatic flexure of colon. The lever here. So hepatic flexure of colon, and that's the transverse colon up to the right 2/3. Up to the right 2/3. This is the midgut. To summarize, the midgut begins from the lower half of second part of duodenum to the right 2/3 of transverse colon. You following? Now what are we left with? The left 1/3 of transverse colon. This bend. The spleen here, spleen. So the splenic flexure of the colon, the descending colon, the sigmoid, the rectum, the anal canal. all this is going to be what? The hindgut. Okay, so this you have to have foregut, midgut and hindgut. And what is so specific? There's someone who ends at midgut. Who's that? If you can just tell me. Someone ends at midgut. Yes, it will be loaded. Someone ends at midgut. Vagus. This is what I was telling you. The vagal supply, the vagal parasympathetic supply ends at midgut. And after this, the hindgut and the pelvic organs would be supplied by whom? The hindgut and the pelvic organs would be supplied by whom? Nervi erigent. That's S2, S3, S4. The sacral outflow of the parasympathetic nervous system. Sacral outflow of the parasympathetic nervous system. That's S2, S3, S4. Fine. So that would supply the hindgut. So I'll just tell you this foregut, midgut and hindgut. Foregut extends from mouth to upper half of pelvic splanchnic is S2, S3, S4. That I have to tell you. Extends from the mouth to upper half of second part of duodenum. Extends from the mouth to upper half of second part of duodenum up to the opening of bile duct. Up to the opening of bile duct. Also includes liver, pancreas and spleen. Also includes the liver, pancreas and spleen. Okay. Next, midgut. Lower half of second part of duodenum. Lower half of second part of duodenum to right 2/3 of transverse colon. To the right 2/3 of transverse colon. Hindgut, left 1/3 of transverse colon to anal canal. Left 1/3 of transverse colon to anal canal. Nutcracker sign is compression of superior mesenteric artery. Compression of the left renal vein between the superior mesenteric artery and the aorta. Compression of the left renal vein. Or the left renal artery between the superior mesenteric artery and the aorta. Okay, I'll tell you that. This is clear? Done? So understand this now. Okay, I'll tell you that. I'll show you the slide later for that nutcracker sign. Clear to all of you? Okay, so that's about the arteries. Now starting with the celiac trunk. Starting with celiac trunk. Just listen to what I'm telling. Don't sit and ask. Whatever is important, I'll tell you. Celiac trunk. There are three main branches of celiac trunk. Left gastric, splenic, common hepatic. If you are having the notes, just look at the notes and read that. Okay, don't sit and ask questions from the notes. When you ask questions, I immediately come to know how many of you are having notes. Okay, so left gastric, splenic and common hepatic. So these are the three branches of the celiac trunk: left gastric, splenic and common hepatic. Just have a look at this. Then I tell you, then we go into details. Left gastric, splenic and common hepatic. Okay, I start. Look at this slide. Now tell me, what is this here? What is this? Don't write anything, just listen to this. This is the falciform ligament. What's that? Falciform ligament. Falciform ligament. Falciform ligament is a fold of peritoneum from the anterior abdominal wall to the liver. And what is this? What is this structure within the falciform ligament? This is the ligamentum teres. Ligamentum teres. Okay. So what is within the falciform ligament? That's the ligamentum teres. Okay, I'll start here. Just concentrate. This is very important. Okay. What is this now? What is this? That's a celiac trunk. These are very important slides, and slides will be clear only if your concepts are clear. Okay. So have a look at this slide. Tell me now. This celiac trunk gives the first branch. What is this artery? The left gastric artery. That's the left gastric. What is this artery? That's the splenic artery. And what's this? This is the common hepatic artery. Okay. So three main branches. One is the left gastric, second is splenic, and third is common hepatic. Now you tell me, what is this for the stomach? I make something like this. What is this for the stomach? Lesser curvature. That's a greater curvature. What is this between the liver and the stomach that we have cut? What is this that we have cut here? Tell me, what is this that we have cut? Which extends between the liver and the lesser curvature of stomach. That's the lesser omentum. Lesser omentum. Okay. So we've cut the lesser omentum here. We've cut the lesser omentum and we've cut the stomach. So the left gastric artery goes along the lesser curvature in the lesser omentum and will anastomose with the right gastric artery. Anastomose with the right gastric artery. Okay. So the left gastric artery enters along the lesser curvature in the lesser omentum, and this will anastomose with right gastric artery. Don't write anything, just listen. That's the splenic artery. The splenic artery runs on the superior border of the body of pancreas. It runs on the superior border of the body of pancreas. It gives branches to the pancreas. Branches to the pancreas. What are these branches? Pancreatic branches. These are the pancreatic branches. Then it enters the hilum of the spleen. It enters the hilum of the spleen. It gives branches to supply the fundus of the stomach. What are these branches known as? Short gastric branches. Short gastric. So what are the branches of spleen? What are the branches of splenic artery? I'm so sorry. Branches of splenic artery. One are the pancreatic branches. Second would be the short gastric branches. Short gastric branches. And it gives an artery which runs along the greater curvature of the stomach. Along the greater curvature of the stomach, and this is the left gastroepiploic artery. Left gastroepiploic artery. Clear? So branches of splenic artery would be one, pancreatic branches, second, short gastric branches which supply the fundus, and the third one is the left gastroepiploic artery. Left gastroepiploic. So just write down branches of splenic artery. Branches. Left branches would be pancreatic, short gastric, pancreatic branches, short gastric branches, and the left gastroepiploic artery. The left gastroepiploic artery. Okay. So pancreatic branches, short gastric branches, and the left gastroepiploic artery. And now who's left here? Just have a look at this. Who's this? This is the common hepatic. The common hepatic artery gives one. The common hepatic artery gives one. What is this now? This is the right gastric artery. Right gastric. Second, gastroduodenal. And the one which is left will go to the liver. And this is what we call as the hepatic artery proper. Hepatic artery proper. So the common hepatic artery gives three branches. One, is right gastric, second is gastroduodenal, and the third one is known as the hepatic artery proper. I'll tell you this once again, just write this down and then we'll see. So common hepatic has three branches. One, right gastric. Second, gastroduodenal. And the third one is hepatic artery proper. Hepatic artery proper. Now gastroduodenal gives further two branches. One is the superior pancreaticoduodenal, and the other one is right gastroepiploic. Right gastroepiploic, superior pancreaticoduodenal and the right gastroepiploic. Just go through this once, then I'll quickly show you the slides. Gastroduodenal gives superior pancreaticoduodenal and the right gastroepiploic. Clear to all of you? Okay. So that's about the celiac trunk. Okay, clear to all of you? So celiac trunk is the artery of the foregut. Vertebral level T12. Three main branches: left gastric, splenic, common hepatic. Left gastric artery enters the lesser curvature in the less omentum, anastomosis with right gastric. Okay, enters the lesser curvature in the less omentum, anastomosis with right gastric. I have not written that. Splenic artery runs on the superior border of the body of pancreas, gives branches to the pancreas, pancreatic branches, short gastric branches, and then the left gastroepiploic artery. The common hepatic gives three branches. One is the right gastric, second gastroduodenal, and then itself continues as the hepatic artery proper. The gastroduodenal gives two branches. One is the right gastroepiploic and the superior pancreaticoduodenal. Is this clear to all of you? Now understand what I am telling you now is very important. Celiac trunk. Celiac trunk, you just need to know these branches. It's easy. You just need to know these branches. Okay, you can make a diagram later. It's a line diagram, you can make it. It's very easy. Okay, I'll start. Have a look at this slide now and try to understand this. I'll start. Now what I'm telling you now is very important. Have a look. Just once again, understand the celiac trunk for you once again. That's the celiac trunk. This artery, what is this artery? This is the, that's the left gastric, that's the splenic, that's the common hepatic, this is the right gastric, this is the gastroduodenal, and that's the hepatic artery proper, Clear to all of you? Now, understand this now. What I'm telling you now is very, very important, okay? Have a look. I'll start. Now, just imagine we've got the duodenum here. Otherwise, the duodenum would be going like this. Duodenum would be ideally going like this. Which is this part of duodenum? First part. That's the first part of duodenum. This is the second part, and down will be the third part of duodenum. So we've cut the duodenum. So he's drawn the duodenum like this, coming down. Otherwise, the duodenum would be ideally like this. That's the first part of duodenum. Okay. Now, if that's the first part of the duodenum, tell me now, what is this before that, okay, this is the duodenum. Now tell me, what is this curvature of the stomach? Lesser curvature. What is this curvature of the stomach? Greater curvature. Fine. What is this between the lever and the lesser curvature of stomach? What is this between the lever and the lesser curvature of stomach? This is the lesser omentum. Lesser omentum. Between the lever and the lesser curvature of stomach, that's the lesser omentum. Tell me, if any structure has to go to the lever, or if it has to come from the lever, there's only one way to go to the lever or come from the lever. Just understand the concepts now. Do not talk, just listen. Don't write anything. If any structure has to go to the lever, or if it has to come from the lever, there's only one way. There's only one fold of peritoneum which can take it, or which it can come down from the lever, and that's the lesser omentum. Lesser omentum, you following? That means if any structure, if it has to go to the lever or come from the lever, it has to pass through lesser omentum. It has to go through the lesser omentum. Now there are three structures present within the lesser omentum. One, hepatic artery, second, portal vein, and third is the bile duct. Hepatic artery, portal vein, and bile duct. These three structures are present within the lesser omentum. Following? Hepatic artery, portal vein, and bile duct. These are the three structures present within the lesser omentum. But out of these three structures, they are just not randomly placed. In the lesser omentum, they are not randomly placed. They have got a definite relation. Definite relation. See the relations of these three structures. Hepatic artery, portal vein, bile duct. How are they placed? Out of all these three, who's the most posterior? The most posterior, portal vein. Portal vein. Who's to the right of the portal vein? To the right of the portal vein is the bile duct. Duct is dextro. Dextro meaning right. So duct is on the right side. Most posterior, portal vein. To the right of the portal vein, bile duct. To the left of the portal vein, hepatic artery. You understanding? Understood the concept? Yes? Look, again I'm telling you. Any structure, if it has to go to the lever or come from the lever, it has to pass through the lesser omentum. This is clear? So there are three structures within the lesser omentum: hepatic artery, portal vein, and bile duct. Clear? They have got a definite sequence. How's the sequence? Out of these three, who's the most posterior? The most posterior, portal vein. The most posterior is portal vein. To the right of the portal vein is what? Bile duct. To the left of the portal vein is what? Hepatic artery. And there's someone behind the portal vein. Behind the portal vein. IVC. IVC. There's someone behind the portal vein. That's IVC. And between the portal vein and the IVC, there's a foramen here. What's that? Epiploid foramen. Epiploid foramen. So epiploid foramen, the anterior boundary would be formed by whom? Portal vein. And epiploid foramen ka posterior boundary would be the IVC. Am I clear? Okay, look at this slide and try to identify what I'm telling you now. Look, just focus and concentrate on this slide. Many things will be clear in this single slide. Okay, I'll start. Look, what is this structure in blue? That's the portal vein. In blue is the portal vein. Okay, so to the right of the portal vein is what? Look at that. What's this in green? Bile duct. To the left of the portal vein is what? See, bile duct is to the right now. If you compare this artery, it is to the left. Okay, there's a comparative. To the left is what? Hepatic artery. Okay, so this is the portal vein. To the right is the bile duct. To the left is the hepatic artery. Behind the portal vein is IVC. And here, there's a foramen here. It's not seen in the slide. I'll show you in the other slide. And this is the epiploid foramen. Okay, so epiploid foramen ka anterior boundary would be portal vein, the posterior boundary would be IVC. Understand? There are plenty of things to understand. Huh? Okay, so clear? Understanding this? Relations of these three structures in the lesser omentum is clear. Posterior portal vein, to the right is bile duct, to the left is hepatic artery. Okay, now starting, have a look. We've got the duodenum. The duodenum has come down. Otherwise, the duodenum would be going like this. like this. That's how the duodenum goes. So now you tell me, what is this part of the portal vein? This part of the portal vein is above the duodenum. We call this as the supraduodenal part of the portal vein. Now this part of the portal vein is going to be behind the duodenum. We call this as the retroduodenal part of the portal vein. And this part of the duodenum, this part of the portal vein will be below the duodenum, behind the pancreas. And this would be the infraduodenal part of the portal vein. Is this clear? So supraduodenal part, retroduodenal part, and the infraduodenal parts of the portal vein. Okay, look at this once again. The part of the portal vein above the first part of duodenum, supraduodenal part, behind the first part of the duodenum, retroduodenal part, and below the first part of the duodenum is infraduodenal part. Am I clear? Look, this is so nice. This is so nice. Understand the relations of portal vein. A very important topic is the portal vein. Okay, understand the relations of the portal vein. Supraduodenal part of the portal vein. Supraduodenal part. Okay, don't write anything. I'll be writing this. Just concentrate. Supraduodenal part of the portal vein. Yeah, that's the supraduodenal part. To the right, bile duct. To the left, hepatic artery. Posterior, IVC. Easy. Come down. What is this part of the portal vein? Retroduodenal part. To the right, what's that? Bile duct. To the left, again I'm telling you, you'll feel the gastroduodenal arteries to the right only. But if you compare the bile duct and the gastroduodenal artery, bile duct is more on the right side. Gastroduodenal arteries towards the left compared to the bile duct. So retroduodenal part of the portal vein, that's the retroduodenal part of the portal vein. To the right is bile duct. To the left is this artery, gastroduodenal artery, and who's behind? IVC. Behind is IVC. And come down. What's this? Infraduodenal part of the portal vein. Who's in front? Who's in front? The pancreas, the neck of the pancreas, to be very specific, neck. And who's behind? IVC. IVC. You understanding? Look, understand this now. I've finished the portal vein with all the relations of portal vein. Look, this is so nice and so easy to understand. Have a look. I'll start once again. So we are starting with the portal vein, and now you tell me, who's behind the portal vein through its entire extent? Who's behind the portal vein in its entire extent? IVC. Who's to the right of the portal vein? Bile duct. And who's to the left of the portal vein? Hepatic artery, and then gastroduodenal artery. Okay, now understand the supraduodenal part of the portal vein. Understand the relation. This should be on the tip of your tongue. Supraduodenal part of the portal vein. I start to the right, bile duct. To the left, hepatic artery. Posterior, IVC. Retroduodenal part of the portal vein. To the right, bile duct. To the left, gastroduodenal artery. Posterior, IVC. Infraduodenal part of the portal vein, anterior, neck of the pancreas. Posterior is the IVC. That's it. Wow, it's nice. Understand, that's the portal vein. Okay, clear to all of you? Yes. And now see, if you know this, you tell me now, which part of the duodenum is this? Which part of the duodenum is this? This is the first part of the duodenum. That's the first part of the duodenum. And what are the posterior relations of the first part of the duodenum? The posterior relations of the first part of the duodenum would be the bile duct, the gastroduodenal artery, and the portal vein. See, automatically you know so many things. So the posterior relation of the first part of the duodenum is going to be the bile duct, the gastroduodenal artery, and the portal vein. Understanding that becomes the posterior relations of first part of the duodenum. These are very important clinical questions. If you know anatomy well, everything is going to be easy for you. Be confident in your basic sciences. Okay. Now, ulcer in the duodenum is common in the first part. Okay. Duodenal ulcers common in the first part of the duodenum. And if the ulcer is going to erode the posterior wall of duodenum, which vessel is going to be ruptured? Understanding it? An ulcer eroding the posterior wall of the first part of the duodenum, which artery is going to bleed? The gastroduodenal artery. Understood? Gastroduodenal artery. That's it. That's it. This is the gastroduodenal artery. Following, no? So behind the first part of the duodenum is gastroduodenal artery. Yes, very good. And now you know something about the pancreas also. Look, I'm just trying to tell you all the things that are coming in my way. Just be with me. You'll understand everything. Don't get confused. Now you tell me, who's the posterior relation of the neck of the pancreas? Immediate posterior relation of neck of the pancreas is going to be portal vein. Following, no? Because portal vein ka anterior relation is neck of the pancreas, so neck of the pancreas ka posterior relation is going to be portal vein. Understood? So starting with the portal vein, I'll tell you one more thing. Bile duct, I'll tell you. No, we'll first finish portal vein. Okay, we'll first finish portal vein. Things are very nice to understand. You just have to know these things and then keep on repeating it. Okay, starting with portal vein. Abdomen, plenty of relation and the small thing. That is why, you know, once you get an idea, now it is very easy. Portal vein, starting with one, supraduodenal part. Supraduodenal part of the portal vein. Anterior and right. Anterior and right. Who's that? Bile duct. Anterior and left. If I take part, posterior, IBC. Posterior is IBC. Starting with second, retroduodenal part. Retroduodenal part. Anterior and right. That's bile duct. Anterior and right is bile duct. Left gastric artery runs along the lesser curvature. Are my dear child, let me finish the celiac trunk now. Why are you asking me superior and inferior mesenteric arteries? I'm telling you celiac trunk, just understand that first. Then we'll go to the superior and inferior mesenteric. No, just understand the things which I'm telling first. Anterior and right is bile duct. Anterior and left. This is a change here. Gastroduodenal artery. That's a change here. Gastroduodenal artery. Posteriorly, IBC. Domain number 3, infraduodenal part. Infraduodenal part, anteriorly, neck of the pancreas, posteriorly, IBC. This should be clear. You see the slides. The more you see the slides, now the more your concepts will be clear. Don't ask any other questions and disturb. Concentrate. These things are very important. Just concentrate on this. Don't keep on asking anything other than these topics. I'll be going through the superior and inferior mesenteric arteries, everything. Okay. So that's about the bile duct, and once you that's about the portal vein. And once you understand the portal vein, you'll understand the bile duct also. Have a look at this. Understand this bile duct. Okay, clear to all of you. Portal vein. Slides, you'll get all the slides. Ali. Okay. Now understand this. bile duct. Bile duct. Now just understand this. This is the first part of duodenum. Look, that's the first part of duodenum. Once again, that's the first part of duodenum. That's the first part of duodenum. Okay, and this is the bile duct. I'll start now. What is this part of the bile duct? Supraduodenal part. What will be this behind the first part of duodenum? Retroduodenal part. And what is this going to be? The infraduodenal part of the bile duct. Infraduodenal part. Understand this bile duct now. Understand the bile duct. Like the portal vein has got three parts. Here, look here once again. See, this is the first part of the duodenum. First part of duodenum. So this is the bile duct. Like the portal vein, the bile duct also has got three parts. The first part is above the part of the bile duct above the first part of the duodenum. That's the supraduodenal part. Behind the first part of the duodenum is retroduodenal part, and below the first part of the duodenum is infraduodenal part of the bile duct. Infraduodenal part of the bile duct. Okay. So understand the relations of the bile duct. Okay, I'll start. Have a look. Supraduodenal part of the bile duct. Now tell me, bile duct itself is on which side? Bile duct is on which side? Right side. So to the left of the bile duct is going to be what? Hepatic artery. To the left, bile duct itself is on the right side. So to the left would be what? Hepatic artery, and posteriorly would be what? Portal vein. Portal vein. Okay. To the left of the bile duct, hepatic artery, posterior would be portal vein. Now, which is this part of the bile duct? This is the retroduodenal part of the bile duct. To the left is this. What is this? Gastroduodenal artery. Gastroduodenal artery. And posteriorly, the portal vein goes like this. Portal vein goes like this. So who's behind this? Directly IBC. I'll show you in some other slide. So retroduodenal part of the bile duct. Who's to the left? Gastroduodenal artery. And who's posteriorly? IBC. And the last one, infraduodenal part of the bile duct. Infraduodenal part. Who's anterior? What is this now? This is the head of the pancreas. Anteriorly is going to be the head of the pancreas, and then it enters inside the head of the pancreas. Okay. Look, how do you understand this? Listen here. Bile duct itself is on which side? Right side. So the supraduodenal part of the bile duct. To the left, hepatic artery. Posterior, portal vein. Retroduodenal part of the bile duct. To the left, gastroduodenal artery. Posterior is IVC. This is slightly difficult. This is not very evident in the slide. I'll show you in some other slide. And infraduodenal part of the bile duct, whose anterior, head of the pancreas. Head of the pancreas. Now tell me, which part of the pancreas is more prone to cancer? Which part of the pancreas is more prone to CA? The head of the pancreas. And when there's a CA of the head of the pancreas, who's compressed bile duct, what does the person get? Obstructive jaundice. The person gets obstructive jaundice. Understanding? So that's how it is. I'll show you the slide. I'll show you this in a different slide. Just write this down first. Yes. Starting with this. Bile duct. Bile duct and portal vein, similar relations are there. Okay. You understand portal vein, you understand the bile duct. The sequence. Supraduodenal part. Remember how to remember this. Bile duct is on which side? Bile duct. Wait, I'll tell you. Bile duct itself is on which side? Right side. So, to the left. To the left. Hepatic artery. Posteriorly. Portal vein. Posteriorly is the portal vein. Retroduodenal part. To the left. gastroduodenal artery. To the left is gastroduodenal artery. Posterior, IBC. This is a change. Posterior is the IBC. Because portal vein goes to the left side. Portal vein goes to the left side. So immediately behind the bile duct is going to be IBC. This I'll show you in some other slide. Retroduodenal part, infraduodenal part. Head of the bile. Yes. You can take that photograph of that diagram. I'll put the diagram, you take the photograph of the diagram. Okay, all the slides will be uploaded. It is there on the page also. Is this clear to all of you? Bile duct, portal vein? Yes. Okay, you can take this slide. I'll just minimize it. You can take this photograph. No photos, but this side you take, that's fine. Because this slide, without the slide you will not understand anything. Without the slide you will not understand portal vein, the bile duct and all. Okay, and look, this is so nice, look. Can't take the screenshot. Okay, fine, it's okay. I'll put this somewhere. All the slides will be uploaded for you, plus all the slides are there on eMedicals also. Okay, just see one thing. Listen here now. What I'm telling you is, what have we done? What have we done to see this? We have taken the lever up. We've taken the lever up like this to see all the structures. Now, you place the lever back. We place the lever back like this. And look, what is this part of the duodenum here? What is this part of the duodenum? First part of the duodenum. If you place the lever back like this, that's fine. Listen here. If you take the lever back like this, then who's going to lie on the first part of the duodenum? Look here. Don't type here. Just wait. This is the body of the gallbladder. If you put the lever back like this, if you put the lever back like this, down like this, you put the lever down. We've taken the lever up, and what are you seeing? This green thing here? Gallbladder. Now, if you put the lever back like this, the body of the gallbladder would come to lie over the first part of the duodenum, and the fundus of the gallbladder would come to lie over. What is this structure here? What would this structure here be? The transverse colon. You understanding? We've taken the lever up, and that's the gallbladder. If you place the lever back like this, the body of the gallbladder would lie where? On the first part of the duodenum, and the fundus of the gallbladder would be lying on the transverse colon. This is very important, because if there's stone in the fundus of the gallbladder, and if it erodes the fundus, which is the organ immediately below the fundus that it will encounter, transverse colon. And if there's a stone in the body of the gallbladder, if it erodes the body, who's the structure behind the body? The first part of duodenum. Understanding this? Okay, that connection went off in between. Fine, what I was telling you, clear with the bile duct now? See, what I was telling you is, listen. Fine. Listen. Wait, let me finish this. Not break. That screen went off. Now what I'm telling you is, to see this thing, what have we done? We've taken the lever up. You're following? We've taken the lever up to see this structures. Now, what I was showing you like this. Look, we've taken the lever up And what is this green structure below the liver? That's the gallbladder. We've taken the liver up to see this thing. Now, if we place this back, what happens? The body of the gallbladder, that's the body of the gallbladder, would lie over the first part of the duodenum. If you place this back, the body of the gallbladder would lie exactly over the first part of the duodenum, and the body of the gallbladder would lie over the first part of the duodenum, and the fundus of the gallbladder would lie over what? The transverse colon. This is something that you have to know. Okay. So we've lifted the liver up, you put the liver back, the body of the gallbladder would lie over the first part of the duodenum, and the fundus would lie over the transverse colon. This is very important, because if there's a stone in the fundus of the gallbladder, which is the organ which it is going to encounter posteriorly, the transverse colon, and if there's a stone in the body of the gallbladder, it erodes the body, which is the structure behind it, the first part of duodenum. Is this clear? Okay, understanding? Don't sit and discuss now, just listen to what I'm telling. So indirectly now what do you know? You know the relations of the first part of the duodenum. I finished portal vein, I finished bile duct for you. Indirectly you know now the relations of the first part of the duodenum. Look, the first part of the duodenum, I'll finish the duodenum, you'll not even understand how I finish the organs. So be with me, don't sit and type and sit and discuss. If you don't understand, you don't tell me later, I'm telling you. Okay, now see, what are the relations of the first part of the duodenum? Who's behind the first part of the duodenum? The bile duct, the gastroduodenal artery and the portal vein. The bile duct, the gastroduodenal artery and the portal vein, they are behind the first part of the duodenum. And who's the anterior relations of the first part of the duodenum? The body of the gallbladder. The body of the gallbladder becomes the anterior relation of the first part of the duodenum. So this is how I'll finish the organs. Okay, clear to all of you? Fine. So that's about the celiac trunk. Starting with the next artery now, starting with the superior mesenteric artery. Superior mesenteric artery. Superior mesenteric artery. Branches. There was a hang. I've repeated that same thing. I've repeated the same thing now. Starting with superior mesenteric artery. I'll repeat it later once again. Just have a look. Superior mesenteric artery. What are the branches? One. Superior pancreaticoduodenal artery. This would be inferior, no? Because superior is a branch of, this is the inferior pancreatico. I'll repeat that. See, what I was telling you is, the body of the gallbladder lies over the first part of the duodenum, and the fundus of the gallbladder would lie over the transverse colon. So if there's a stone in the fundus of the gallbladder, which is the organ which it is going to encounter behind the transverse colon, and if there's a stone in the body of the gallbladder, what is the organ which it is going to encounter behind? If it erodes the wall, that's the first part of the duodenum. So what I was telling you is, the relations of the first part of the duodenum you are perfect with now. Anterior relations of the first part of the duodenum is body of the gallbladder, and the posterior relations of the first part of the duodenum is the bile duct, the gastroduodenal artery and the portal vein. Okay, fine. So now we come to this once again. Inferior pancreaticoduodenal artery. Second, jejunal and ileal branches. Let me finish this two arteries before the break. Jejunal and ileal branches. Third, middle colic artery. Right colic artery. Ileocolic artery. Middle colic, right colic, ileocolic. Ileocolic gives an ascending branch, descending branch. Descending branch gives 4 branches. Anterior cecal, posterior cecal, appendicular, iliac. Okay, so appendicular artery is very important. Appendicular artery is a branch of the descending branch of ileocolic. Appendicular artery is a branch of descending branch of ileocolic. Okay, so what are the branches of superior mesenteric artery? The first branch is the inferior pancreaticoduodenal. The inferior pancreaticoduodenal is going to anastomose with the superior pancreaticoduodenal artery. Second, jejunal and ileal branches. Third, middle colic. Next, right colic. Next, ileocolic. Ileocolic gives an ascending branch, descending branch. Descending branch gives 4 branches. One, anterior cecal, posterior cecal, appendicular and ileal. So tell me now, appendicular artery is a branch of appendicular artery is a branch of descending branch of ileocolic artery. Appendicular artery is a branch of descending branch of ileocolic. There's sometimes an artery, this appendicular artery itself gives a branch, and this branch goes in the reverse direction of the appendicular artery. Anything going in the reverse direction is what? You remember the recurrent branch of mandibular nerve? It was going in the reverse direction of the mandibular nerve. And what was this recurrent branch? Also known as nervus spinosum. Enters the skull through the posterior cranial, enters the skull through foramen spinosum. I'm so sorry. Enters the skull through the foramen spinosum and supplies the meninges of middle cranial fossa. You know this. Similarly, this is a branch of appendicular which goes in the reverse direction. What's that? Recurrent appendicular artery. It's a branch of appendicular. It's a branch of appendicular or posterior cecal. If not appendicular, it would be a branch of posterior cecal. And sometimes there's an extra artery. Anything extra is known as what? Anything extra, accessory. Like accessory, where have we come across this term? Accessory phrenic nerve. Arises from C5 root of the brachial plexus, and this is the accessory appendicular artery, branch of posterior cecal artery. Posterior cecal. Okay, so you just have to know this. There are 3 arteries by the name of appendicular. One is our main appendicular artery, which is a branch of descending branch of ileocolic. Recurrent appendicular artery is a branch of appendicular or posterior cecal, and accessory appendicular artery is a branch of posterior cecal. Just remember all these things, okay? And now last one, inferior mesenteric artery. Inferior mesenteric artery what are the branches? 1, left colic. Second, sigmoid branches. And third, superior rectal artery. It's a continuation of inferior mesenteric. Continuation of inferior mesenteric. Superior rectal artery is a continuation of inferior mesenteric. Yes, there are aerial branches. Appendicular artery, clear to all of you? Sheshachalam, that's right. So inferior mesenteric artery branches are left colic, then sigmoid branches, and superior rectal artery. Superior rectal artery Superior rectal artery is a continuation of inferior mesenteric artery. Superior rectal is a continuation of inferior mesenteric artery. Clear to all of you? Now just see the slide which I am drawing. This is a very important slide and have a look at this. Okay, just see this. Don't draw anything, just have a look. All the arteries will be clear. And why this artery is so important, because behind this artery is there's someone who lies, the ureters. The ureters are lying behind these branches of these arteries. So the moment you know all these arteries, you will immediately understand the ureters. Don't draw anything, just have a look here. That's a cecum, that's an appendix. Okay, I'll start. Have a look here. Do not draw anything, please. Just concentrate here and try to understand this. If this is clear now, plenty of things are easy. I'll start. Have a look. What is this artery which runs towards a convexity, with a convexity towards the left side? Which is this artery which runs with a convexity towards the left side? That's a superior mesenteric artery. And what is the first branch going up? This is the inferior pancreaticoduodenal artery. The first branch, inferior pancreaticoduodenal. It gives many branches from this side. From its convex side, it gives jejunal and ileal branches. Jejunal and ileal branches. Okay. Now, we are inside the loop of the colon. We are inside the loop of the colon. The first branch here within the loop, what's this known as? Middle colic. The middle colic will give two branches. The small branches I have not told you. This is the left branch, this is the right branch of middle colic. Okay. The next artery is going to be, one moment, the next artery is going to be right colic. The right colic will give an, this is the right colic, will give an ascending branch which anastomoses with the right branch of middle colic, and this is the descending branch of right colic. And the third artery, I've told you in details, the third artery. Which is the third artery here? This is the third artery is the, one moment, this is the ileocolic. The ileocolic gives an ascending branch which anastomoses with the descending branch of right colic, and the descending branch of ileocolic itself anastomoses with the superior mesenteric artery. Descending branch of ileocolic anastomoses with superior mesenteric. Okay. The descending branch of ileocolic gives four branches. This you know now. What are those four branches? One is the anterior cecal, second is the posterior cecal, third is the appendicular, and fourth is ileal. Understood? Look here once again. This artery is the middle colic. Middle colic gives two branches, right and left. The small branches I have not told you. The right colic gives an ascending and descending branch, and the ileocolic gives an ascending and descending. The descending branch of ileocolic anastomoses with the superior mesenteric artery. Okay, understand this now. What is this artery now? This artery is the inferior mesenteric artery. And what is the first branch of inferior mesenteric? The first branch, I just have to keep on changing this colors, just 2 minutes. What is this artery? This is the left colic. The left colic will give a right branch which anastomoses with the left branch of middle colic, and this is a descending branch of left colic. Okay, and the next artery which are given are the plenty of this arteries by the name of, what are these arteries known as? The sigmoid branch. The first sigmoid artery anastomoses with left colic, and then this sigmoid arteries will anastomose with each other, and the continuation of the continuation of inferior mesenteric artery is now known as what? What is this continuation known as? The superior rectal artery. Superior rectal. Just wait, listen to this first. Now tell me, there's an anastomosis here. There's an anastomosis here. There's an anastomosis here. Here, and here. And because of this anastomosis, a continuous artery is formed along the margins of the colon. And this is what we call as the marginal artery of Drummond, marginal artery of Drummond. Remember, marginal artery is not a actual artery. It is just formed because of anastomosis between different arteries, and this is the marginal artery of Drummond. And from this marginal artery, you get such straight branches. One moment. These are the straight branches, and these straight branches will enter the walls of the colon, and it is going to supply the walls of the colon. Anything straight is known as what? Straight. Rectus. Straight is rectus. Blood vessels are known as what? Vasa. So these are the vasa recti. And this vasa recti are going to enter the walls. They arise from the marginal artery of Drummond, and they are going to supply the walls of the colon. Is this clear to all of you? So this is the slide. This is the complete slide. You have to know this, because if you know this, you understand the... I'll show the actual slide. I'll show the actual slide. Just one moment. I'll label this for you. Draw this, draw this. Draw this. This is very important. If you know this, automatically you understand the relations of ureter. Ureters plus you have to know all these branches of the vessels. This entire artery is the marginal artery. I'm labeling it here. Doesn't mean that this is marginal artery. Marginal artery is the complete artery which is formed along the margins of the colon. I'll just label it here. Have you followed all these things? Ileocolic, I have given you the arteries the same I have labeled. Just see what you have written and try to understand. See the arteries what you have written. Superior mesenteric branches you have written, inferior mesenteric branches you have written. The first branch of superior mesenteric going up is inferior pancreatic duodenal. From its convex sides, jejunal and ileal branches. The first branch middle colic, the next is right colic, the third is ileocolic. Inferior mesenteric artery, the first branch is left colic, then is sigmoid branches, and the continuation is the superior rectal artery. SRA is superior rectal artery. I'll show you the slide, it will be clear. I'll show you the actual slide, don't get confused. We are still discussing the posterior abdominal wall, remember. So posterior abdominal wall, I have told you the muscles on the posterior abdominal wall. We've seen the plexus, lumbar plexus. We've seen the vessels on the posterior abdominal wall. Okay. Inferior colic. What is inferior colic? It is ileocolic. Ileocolic. You have written that. Branches. You have written the 4 branches. Why are you asking me now? You have written those 4 branches of ileocolic. Vasa recta are those straight branches which enters into the walls of the colon. Vasa recta. IRC. What is IRC? Marginal artery is a complete artery formed due to anastomosis. Like this. That anastomosis. That's the marginal artery. I'll show you the slide. Just one moment. I'll show you the actual slide. You'll understand. If you're done, you tell me. Marginal artery is the entire artery, not the small. The small orange ones are the vasa recti. Marginal artery is the common artery. Sigmoid branches, SIG is sigmoid branches. You just see what branches you have written. I've given you this in writing, no? Superior mesenteric branches you have written, inferior mesenteric branches you have written. Same I've labeled. In short, I've labeled that. The brown one is left colic. Brown one is left colic. I'll tell you, just wait. Marginal artery of Drummond, I'll show you. Just wait, have some patience. Brown one is left colic. If you're done, you tell me. IRC नहीं है वो, left है left. This is the left. IRC नहीं है, that's left colic. Okay. Pink are the descending, yeah, pink are the branches, descending branches of ileocolic. Yes. Pink are the descending branches of ileocolic. Who's repeating, who's asking me again and again, marginal artery of Drummond? I told you, no, I'm telling you marginal artery. Just wait, no. Okay, I'll start. Have a look. See, this is the slide. This is the actual slide. Just one moment. You'll understand everything. Just have some patience. See the slide. Okay, that's it. That's the slide. Okay, I'll start. Now see, I'll start and just concentrate now. Do not write, do not talk. Yo, what is this artery here now? That's a superior mesenteric artery. That's a superior mesenteric artery. The first branch is not seen here because the first branch is given beforehand. It's given already there. What are these branches from its convex side? What are these branches? These are the jejunal and ileal branches. Okay. So those are the jejunal and ileal branches from its convex side. Okay. Now, inside the loop of the colon, inside the loop, what is this branch? The first branch. This is middle colic. And the middle colic gives two branches. Look, the left and the right branch. What is this artery? Right colic. This is the right colic, which gives an ascending branch and descending branch. And what is this artery? Ileocolic. It gives an ascending branch and descending branch. And the descending branch of ileocolic anastomosis with the superior mesenteric artery. Understanding? The descending branch of ileocolic anastomosis with the, clear to all of you, ascending and descending. The descending branch anastomosis with the superior mesenteric. The descending branch gives one. This is the anterior cecal, this is the posterior cecal, this is the appendicular, and one will be ileal. Clear? Now that's the inferior mesenteric artery. This is inferior mesenteric artery. That's the first branch going up. That's the left colic. It gives two branches here. What are these? These are the sigmoid branches. Sigmoid. And what is this continuation known as? This is the superior rectal artery. That's the superior rectal. You're clear now? The continuation is known as superior rectal artery. Now what I'm telling you is, look. There's an anastomosis here. There's an anastomosis here. There's an anastomosis here. There's an anastomosis here. And because of this anastomosis, a continuous artery is formed here. Look at this continuous artery. And this continuous artery is known as what? The marginal artery of Drummond. You understanding? Now this continuous artery which is formed due to anastomosis is known as marginal artery of Drummond. And this straight arteries you can see from the margin. Look at this straight branches. And these straight branches are known as vasa recti. Vasa recti. So vasa recti arises from the marginal artery of Drummond, and the vasa recti will supply the walls of the colon. You should be clear now. You should be perfect. Okay. And why am I telling you this? Why am I telling you this? Because if you can see, what is this? What is this structure? Look at this structure. Look at this structure. Guess. What is this? Guess this. What is the structure which I've pointed? And what is this structure here that I've pointed? Guess this. This is the ureter, and this is ureter, very important. So what is the anterior relation of the right ureter? Following this now, so half of the ureter you know now. Anterior relation of right ureter is going to be 1, the middle colic vessels, the right colic vessels, middle colic has gone up. This is the right colic vessels, the right colic artery, the ileocolic artery. Understand? The relations, anterior relation of left ureter is going to be the left colic artery, the sigmoid branches, Clear? Okay, so that's how it is. Very good. You've understood it. Just 1 or 2 more things, then you take a break. Fine. Okay, just have a look. Just 2 minutes, starting with Griffith's point. Present at splenic flexure of Coulomb. Present at the splenic flexure of Coulomb. Anastomosis between so I'll just make it in short. Anastomosis between superior mesenteric artery and inferior mesenteric artery. Which branch of superior mesenteric? Middle colic. And which branch of inferior mesenteric? Left colic. This point at the splenic flexure of Coulomb is known as the Griffith's point. You can see the slide, you'll understand that. There's an anastomosis between 2 main arteries. Which are the main arteries? Superior mesenteric and inferior mesenteric. Which branch of superior mesenteric is that? Middle colic. And which branch of inferior mesenteric is that? The left colic. Sudeck point. Sudeck's point, S-U-D-E-C-K, Sudeck's point. Present at recto-sigmoid junction. Present at the recto-sigmoid junction. Yes, watershed area. Present at the recto-sigmoid junction. Anastomosis between inferior mesenteric artery and internal iliac. Inferior mesenteric and interiliac. Which branch of inferior mesenteric artery? Superior rectal. And which branch of internal iliac? Just remember all these things. We'll be discussing these things later in the pelvis. Marginal artery of Drummond, nothing specific. It's just an artery which is formed because of anastomosis. Okay, you just have to know that artery is a continuous artery formed along the mesenteric border, that is known as the marginal artery of Drummond. and from this marginal artery you get straight branches which are known as vasa aorta. You're clear with this? Griffith's point and Sudeck's point. Yes, Griffith's point and Sudeck's point. Just one last thing here, understand this. Easy it is. Just one last thing. So that completes my posterior abdominal wall, and then you take a break and start with the abdominal, anterior abdominal. Blood vessels related to pancreas. Blood vessels related to the pancreas. If you know this, you know half of the pancreas, then the relations becomes very easy. This pancreas and all are have plenty of relations. Okay, look here, quickly tell me, what is the anterior relation of first part of duodenum? Anterior relation of first part of the duodenum. Chalo bolo, anterior relation of first part of duodenum, that is the body of the gallbladder. And posterior relation of first part of the duodenum is bile duct, gastroduodenal artery, portal vein. Bile duct, gastroduodenal artery, portal vein. Posterior relation of first part of duodenum. Anterior relation of first part of duodenum, body of the gallbladder. The fundus of the gallbladder is related to transverse colon. I've told you all these things. I keep on repeating this again and again. This thing should be there in your brain. Okay. I keep on repeating it again and again till the time it gets, fixed in your brain. Blood vessels related to the pancreas. Chalo, fine, finish this now. Along the superior border of the body. Along the superior border of the body. Superior border of the body. You know this. That's splenic artery. Splenic artery. Second, behind the body, splenic vein. Splenic vein. On the uncinate process. On the uncinate process. On the uncinate process is superior mesenteric vessels. Superior mesenteric vessels. On the uncinate processes, superior mesenteric vessels, and last, behind the neck, portal vein. Behind the neck, portal vein, in the upper part, and superior mesenteric vein in the lower part. Superior mesenteric vein in the lower part. I'll draw this slide for you, but just understand. Along the superior body of the body, splenic artery. Behind the body of the pancreas is the splenic vein. Then the pancreas has got a process, uncinate process. On the uncinate process lies what? Superior mesenteric artery. And behind the neck of the pancreas, vein of the portal vein lies behind the neck of the pancreas. And what is that part of the portal vein behind the neck of the pancreas known as infraduodenal part of the portal vein? This we know. So behind the neck is portal vein, but in the upper part and in the lower part is the superior mesenteric vein. Okay, I'll show you the slides. Just finish this. Just draw the slide and finish this. I'll show you the slide, so that will complete it. So that's a pancreas here. What is this? Artery here on the superior border of the body here. That's the splenic artery. That's the splenic artery. Behind the body, that's the splenic vein. Splenic vein. On the uncinate process, that's a superior mesenteric vein coming from below. That's a splenic vein, and that's the portal vein. I'll repeat that. I'll repeat that for you. Just wait. Okay, that's how it is. Draw this and label this. That's the splenic artery. That's the portal vein. This is the inferior mesenteric vein, which is a continuation of superior rectal vein. Remember the superior rectal artery? This is blood vessels related to the pancreas. You remember the inferior mesenteric artery continues down as what? Superior rectal artery. Fine. So the superior rectal vein continues as inferior mesenteric vein. Inferior mesenteric joins with splenic. Splenic joins with superior mesenteric and forms the portal vein. So behind the neck of the pancreas, in the upper part is portal vein and in the lower part is the superior mesenteric vein. Just remember, behind the body is the splenic vein. On the anterior process is the superior mesenteric vessels, and on the upper superior border of the body is the splenic artery. Inferior mesenteric vein opens into splenic vein. Yes, inferior mesenteric vein opens into splenic vein. That's right. Is this clear to all of you? Blood vessels related to the pancreas. So with this, you know half of the pancreas. Okay, only half of the pancreas I have to tell you now. Half of the pancreas is known to you. Okay, behind the neck of the pancreas, portal vein in the upper part and superior mesenteric vein in the lower part. That's right. That's right. Just see the slide and see this and just have a look at this. See this slide. This is a very good slide. Have a look. Yep. Fine, I'll start. Tell me now. What is this vein? Yo, what is this vein? One moment, I'll change the color. What is this vein coming from below? That's a superior rectal vein. The superior rectal vein will continue as what? Inferior mesenteric vein. The inferior mesenteric vein will go and join with what? Who's this now? Splenic vein. So the inferior mesenteric vein joins with the splenic vein. The splenic vein comes here, joins with the superior mesenteric vein. And now what is this vein? That's the portal vein. Understanding? Clear? So that's the superior rectal vein. That's the inferior mesenteric vein. That's the splenic vein. The splenic joins with superior mesenteric and forms the portal vein. Clear to all of you? Clear with all of you? Clear to all of you? Uncinate process above, uncinate process. So that's how you remember the slide. Okay. Is this clear to all of you? Any doubts till here? And just look at the slide once again. Just have a look at the slide. Okay, look here. Just 2 minutes. Sudeck point and Griffith's point, you know. Sudeck's point is present at the splenic flexure of the colon. At the splenic flexure, there's an anastomosis between the superior mesenteric and the inferior mesenteric artery. Which branch of superior mesenteric artery? It's the middle colic, and branch of inferior mesenteric artery is the left colic. And the Sudeck's point is present at the recto-sigmoid junction, anastomosis between the inferior mesenteric and the internal iliac. Which branch of inferior mesenteric is it? Superior rectal, and interiliac is middle rectal. That we'll see later. Okay, that's it. Just quickly tell me. What is this? What is this? Suprarenal gland. That's left suprarenal gland. That's the splenic artery. That's the pancreas. That's the left kidney. That's the spleen. And just place an organ here. That's the stomach here. That's the stomach. And all these organs are going to form what for the stomach? The stomach bed. Okay, this one single slide has got so many things to tell us. That's the suprarenal gland. That's the splenic artery. That's the pancreas. That's the spleen. And if you can just tell me, what is this? What is this that I'm showing you? What is this? Chalo bolo. What is this that I'm showing you? Duodenum and all, I'll be telling you later. Don't ask such questions, I told you. I just give a reference. I'm not taught you the duodenum. I'm just giving you a reference so that when I actually come to the topic, it will be very easy for you. I just can't start duodenum, first part, second part, third part, fourth part. I just can't start like this. Okay, and I don't like to start like this. Before I start with the topic, you should be having an idea about that topic. So first part of the duodenum, I've just told you, anterior posterior relation. Like the second part, third part, as we proceed, you'll understand. Okay, and then we come to the actual duodenum, you'll know everything about it very easily. Clear? That's the left crest of the diaphragm. Very good. That's the left crest. So this becomes the posterior relations of the stomach. We'll see this later. Clear to all of you? We take a break then. Take a break. Take a break, 15-20 minutes, and then we start. Lunch break 2:30. Huh? Lunch break will be at 2:30. Okay, clear to all of you? Fine. Take a break. Lunch break 2:30. Starting with anterior abdominal wall. Understand this now. Starting with anterior abdominal wall. Okay, I'll start. Just have a look at this slide. Yep, I'll start. Now, anterior abdominal wall. Understand this and understand the inguinal canal. Now tell me this muscle, external oblique. External oblique is a very big muscle. Where does the external oblique begins from? It arises from the lower 8 ribs, external oblique, arises from the lower 8 ribs. In the upper part, anterior aspect of the lower 8 ribs. In the upper part, it interdigitates with a muscle which arises as digitations here. Who's that? Serratus anterior. In the lower part, it interdigitates with a muscle here, a muscle of the back. A muscle of the back which goes in front and gets inserted into the floor of the bicipital groove. What's that? What is that muscle? Muscle of the back which comes in front and gets inserted into the floor of the bicipital groove. A muscle which forms the posterior wall of axilla. Posterior wall of axilla. Who was that? That was the latissimus dorsi. Latissimus dorsi. So external oblique is a big muscle. In the upper part, it interdigitates with what? Serratus anterior. In the lower part, it interdigitates with latissimus dorsi. Latissimus dorsi. Now just understand, this big external oblique comes down. A part of external oblique gets inserted straight down into the iliac crest. It goes straight down into the iliac crest. A part of external oblique comes in front with the opposite external oblique, forms an interdigitation along a straight line in the center here. What's that line known as? Linea alba. Following this? Look, external oblique is a big muscle. A part of it gets inserted into the iliac crest. Part of it comes in front, but the opposite external oblique forms an interdigitation along this line here. What's that? Linea alba. Now, the part of the external oblique which is left goes down and turns like this. Now this part of external oblique goes down and turns like this. It goes down and turns like this. And the lower part of this turn, becomes thick. And this is what we call as inguinal ligament. Inguinal ligament. You're following? See, external oblique is a big muscle. Arises from the anterior aspect of the lower 8 ribs. In the upper part, it interdigitates with what? Serratus. In the lower part, it interdigitates with latissimus dorsi. Now this big external oblique, a part of it goes into the iliac crest, a part of it interdigitates with the opposite external oblique along this line in the center, that's linea alba, and the rest of the external oblique goes down and turns like this. Okay, I'm starting here now, have a look. It turns and it folds like this and it turns. The lower border of this fold becomes thick, and what's that? Inguinal ligament. Inguinal ligament. I'm starting with inguinal canal. Now, what are the boundaries of inguinal canal? Just see if you can understand like this. Inguinal canal has got an inguinal canal is like a tunnel. It's like a tunnel. It will have an anterior wall, it will have a posterior wall here. See if you can understand like this. It will have a posterior wall here. Anterior wall, posterior wall, it will have a roof, it will have a floor. There's no medial wall, there's no lateral wall. Remember, these two walls are open. So it's like a tunnel. This is the anterior wall, behind is going to be the posterior wall, this is the roof, this is the floor. Okay, I start, just have a look. The anterior wall in its entire extent is formed by whom? What's that? External oblique. The same external oblique goes down and turns like this, forms what? Floor. The lower border of this floor becomes thick, and that's the inguinal ligament. Now just imagine if this is my right side. So this is the lateral and this is the medial aspect, lateral and medial. Now if we're looking from inside, okay, we're looking from inside, from the lateral 2/3 of the inguinal ligament, lateral 2/3, there's a muscle which begins here, from the lateral 2/3. This is the internal oblique. Begins from the lateral 2/3, first goes here, first goes up. If you're looking from front, this muscle goes in front, forms what wall? Anterior wall. On which aspect? Lateral aspect. It forms the anterior wall, but on which aspect? Lateral aspect. Now it goes up, and it forms what? Roof, and it now comes back. So what wall is it going to form? The posterior wall, but on which aspect? Medial aspect. Following this, this muscle starts from the lateral side, goes up and comes on the medial side like this. So it forms the anterior wall on its lateral aspect, it forms the roof above, and it forms the posterior wall on the medial aspect. Here it forms all the three walls. That's the internal oblique. So internal oblique forms the anterior wall on the lateral side, then forms the roof, and then comes and forms the posterior wall on the medial side. There's one more muscle in a similar way. Who's that? Arises from the lateral 1/3 of the inguinal ligament. Who's that? Transverse abdominis. Now this transverse abdominis first goes up. What wall is it forming? Anterior wall. But some books do not mention transverse abdominis. Okay. So I'll tell you this later. I normally tell it forms the anterior wall. It goes up. What does it form now? Roof. And it comes here on the posterior aspect, but on the medial side. So it forms a posterior wall on the medial side like this. Okay, so that's the transverse abdominis. Simple it is. Have a look and tell me now. Look, in its entire extent, the anterior wall is formed by whom? External oblique. In its lateral part, it is formed by internal oblique. We don't take the transverse abdominis, just the internal oblique. The roof is formed by what? Now both this internal oblique and transverse abdominis go up. Now the roof, when the internal oblique and transverse abdominis take origin from the inguinal ligament in front, internal is separate, transverse is separate. But as they go up in the roof, they are going to merge like this. And what is this merge known as? Conjoint tendon. And as we come back along the posterior wall, again they are going to merge like this. What is that merge known as? Conjoint tendon. So internal oblique and transverse abdominis are separate only in the anterior wall. As we go up, it is known as conjoint tendon. As we come back, it is known as conjoint tendon. You're getting this? Yes, following this, all of you? So look, it's very easy. Anterior wall in its entire extent is formed by external oblique. In its lateral part, it is formed by internal oblique. The roof is formed by what? Conjoint tendon. The posterior wall in its entire extent, I've now told you this, the posterior wall in its entire extent is formed by fascia transversalis. I didn't tell you this. It's formed by fascia transversalis in its entire extent. On the medial side, it is formed by whom? Conjoint tendon. And the floor is formed by the external oblique and the inguinal ligament. Is this clear to all of you? Yes? Clear? Now two openings it has. This inguinal canal has two openings. One, this is on the posterior wall. What is this opening? This is a deep inguinal ring, which is a defect in fascia transversalis. And there's a defect here this is the superficial inguinal ring, which is a defect in external oblique aponeurosis. Yeah, so that's the superficial ring and that's the deep ring. So that's how the inguinal canal is. I hope you're following this now. I'm trying to do my level best to explain you. Okay, so that's the inguinal canal. And now you tell me, when the testis is coming down, look, this is so nice, just try to understand. This 2-3 topics I'm finishing simultaneously, they're all correlated. Now, when this testis is descending down from the abdomen, the testis comes into the scrotum. The testis is first inside the abdomen, and as the testis is descending down, before that, just have a look at this layers of anterior abdominal wall. So it will be still clear to you. Okay, have a look at this. What are the layers of anterior abdominal wall? Okay, I'll start here. What is this? After we remove the skin and the superficial fascia, there's no deep fascia for the anterior abdominal wall. So after we remove the skin and the superficial fascia, here, skin and the superficial fascia, this is the external oblique aponeurosis. I'll write that for you later. Just understand this. External oblique aponeurosis. What is this? Internal oblique. What is this? Transverse abdominis. So once we remove the skin and the superficial fascia, the first muscle is external oblique aponeurosis. This is external oblique. That's internal oblique. That's transverse abdominis. What is this? This is the fascia transversalis. Fascia transversalis. This is the extraperitoneal fat, and this is the peritoneum. That's the peritoneum. Just wait, I'll explain that once again. So what are the layers of anterior abdominal wall? After we remove the skin and the superficial fascia, external oblique, internal oblique, transverse abdominis, fascia transversalis, extraperitoneal fat, and the peritoneum. And look, who's this? Yo, who's this? This is what I was telling you yesterday. These are the nerve. Okay, what nerve is this? This is the iliohypogastric, and the ilioinguinal nerves will be here. And this iliohypogastric and ilioinguinal nerves will be present between which two muscles? The internal oblique and the transverse abdominis. You're following this? And this is what we call as the neurovascular plane of the abdomen. So the neurovascular plane of the abdomen lies between what and what? The internal oblique and the transverse abdominis, right? And this three muscles of anterior abdominal wall we compared with the 3 scaleni and the 3 intercostal muscles. There is no medial and lateral border for inguinal canal. If medial and lateral border is there, then how did the testis enter inside the canal and get outside the canal? There's no medial and lateral wall. That's the roof and the floor. Okay. Look here once again. I'll just show you on this. Okay, just try to understand this once again. Inguinal canal. Look. Inguinal canal. Once again, fast. Here. This muscle, what's this? External oblique. The external oblique goes and folds like this. It folds. And the lower part of this fold becomes thick. What is this known as? Inguinal ligament. Okay. So inguinal canal is like a tunnel. So what are the boundaries of it? What is this wall? Anterior wall. You'll have a posterior wall. You'll have a roof and you have a floor. So this would be the boundaries. No medial and lateral wall. So what is this muscle? External oblique. Now we're looking from inside. From the lateral 2/3 of the inguinal ligament, there's a muscle which arises. Who's that? Internal oblique. The internal oblique first goes up. What wall is it going to form? Anterior wall, but on its lateral aspect. It now turns and goes up. So what is it going to form? Roof. And now it comes back. But on which aspect? Medial aspect. So what wall is this? The posterior wall, but on its medial aspect. That's internal oblique. Now there's one more muscle which begins from the lateral 1/3. Who's that? Transverse abdominis. First goes up, then first goes anteriorly, then goes over it. So again, what does it form? Roof, and then comes back. Forms a posterior wall, but on its medial side. Understand one thing, when this internal oblique and transverse abdominis take origin, internal is separate, transverse is separate. But as we go up in the roof, they merge, and what is that known as? Conjoint genital. And as it comes back again, they merge, and what's that? Conjoint genital. Now clear? So look, anterior wall in its entire extent is formed by whom? External oblique. In its lateral part, it is formed by internal oblique. The posterior wall in its entire extent is formed by whom? I didn't tell you this. The posterior wall in its entire extent is formed by fascia transversalis. Okay. On its medial part, it is formed by conjoint tendon. The roof is formed by conjoint tendon, and the floor is formed by the external oblique and the inguinal ligament. It's clear? That's simple, easy. Now you tell me. But the testis is inside the abdomen and the testis is descending down. The testis is getting outside the abdomen. Tell me, what is the first obstruction the testis is going to encounter? The first barrier for the testis. The testis is getting out. Any structure from the abdomen, if it has to get out, get out. What is the first obstruction for it? Fascia transversalis. Fascia transversalis. And as the testis crosses the fascia transversalis, no, that's the peritoneum. I'm so sorry. Clear to all of you? Crystal clear? Okay, very good. Okay, understand this. When any structure from the abdomen has to get out, what is the first thing that it is going to encounter? The peritoneum. Peritoneum. Any structure from the abdomen, if it has to get out, that's the peritoneum. So as the testis is descending down and as the testis is getting outside the abdomen, the first obstruction that it will come across would be the peritoneum. And as the testis crosses the peritoneum is going to enclose the testis in two layers. And what is this known as? The tunica vaginalis. Tunica vaginalis. And now as the testis is proceeding forwards, it finds an opening here. What is that opening? The deep inguinal ring. The deep inguinal ring is a defect in fascia transversalis. Fascia transversalis. Yes. The deep inguinal ring is a defect in fascia transversalis, and as the testis passes through the deep ring, the surrounding fascia transversalis is going to enclose the testis. And what is that known as? Internal spermatic fascia. Internal spermatic fascia. So the testis has now crossed the deep ring. Okay, where is the testis now? It's in the inguinal canal. And as the testis is passing through the inguinal canal, there's a muscle here in the form of loops. What's that? It's in the form of a loop. Cremaster. And as the testis crosses the cremaster, gets a covering from cremaster. What's that? The cremastric fascia. And finally, where's the testis come? What's this opening? That's the superficial inguinal ring. And the testis now gets out through the superficial ring, gets a last covering, the external spermatic fascia, which is derived from external oblique aponeurosis. You're clear? As the testis is descending down, how it gets the covering of different layers of the anterior abdominal wall. Where is the testis now? In the scrotum. Fine, you get an MCQ on this. You're draining a hydrocele. What are the structures that you're going to pierce? So now we start from the scrotum. We start with the scrotum. If you can answer this. Skin, superficial fascia containing muscle of the scrotum, dartos. Skin, superficial fascia containing dartos. Now comes the first covering. External spermatic fascia derived from external oblique aponeurosis. Then cremastric fascia derived from cremaster. Internal spermatic fascia derived from fascia transversalis. Then tunica vaginalis, which derived from peritoneum. Which layer are we going to pierce? The parietal layer. We are in the cavity of hydrocele and you drain the hydrocele. The next layer is going to be the visceral layer, and testis has got its two original coverings. It doesn't just come like that. It has got its two original coverings, the tunica albuginea and tunica vasculosa. So this becomes the coverings of the testis. Following this? So these are all interrelated topics. Just try to understand this. So that's the coverings of testis. And once this is clear, you'll understand the contents of inguinal canal. Contents of inguinal canal, in males it will be what? In males, spermatic cord and, if you can answer this, spermatic cord and ilioinguinal nerve. Spermatic cord and the ilioinguinal nerve. In females, it would be the round ligament of uterus and the ilioinguinal nerve. Ilioinguinal. Okay. Okay, that's it. Very good. So we'll start with the inguinal canal. So the testis gets different coverings and as it is just proceeding. Okay, that's fine. Very good. Starting with inguinal canal, the boundaries. Anterior wall in its entire extent. Conjoint tendon will not be seen in its entire extent. Chalo, start with me first. Entire extent is external oblique. Okay, I'm just writing it in short. Try to understand as you're writing, and this should be perfect. Okay. So anterior wall in its entire extent is formed by external oblique in its lateral part. We just take internal oblique. In its lateral part, internal oblique. Posterior wall in its entire extent fascia transversalis. This is inguinal canal. This is inguinal canal, I'm telling you. Boundaries of inguinal canal. In its entire extent, fascia transversalis. In its medial part, conjoint tendon. Roof. Wait, now I'm telling you the coverings of testis. Just wait. Just be with me. I'll tell you. Roof is formed by conjoint tendon. And flow. External oblique. And inguinal ligament. You want the layers of anterior abdominal wall? Okay, I'll tell you. Layers of anterior abdominal wall, I'll tell you. Okay, that's so nice. Okay, now we proceed. Layers of anterior abdominal wall. Layers of anterior abdominal wall. Skin. Superficial fascia. Remember, there's no deep fascia in the abdomen because the abdomen has to distend. Skin, superficial fascia, external oblique, aponeurosis, external oblique aponeurosis, internal oblique, transverse abdominis, fascia transversalis, fascia transversalis, extraperitoneal fat, peritoneum. I've shown you this slide. I've shown you the slide. This slide of anterior abdominal wall I've shown you. Superficial fatty layer, and that is campus and scarpas. The superficial fascia of the abdomen is divided into two parts. Okay. Clear? Now, coverings of testis. This is another very important MCQ. Coverings of testis. You get MCQs on draining of hydrocele and all. One, just be fast. External spermatic fascia. This is easy. This is very easy topic. So easy topics I tell you, difficult topics also I tell you. External spermatic fascia is derived from external oblique aponeurosis. derived from external oblique aponeurosis. Cremastic fascia. Derived from cremaster. In one of the MCQs, cremastic fascia is derived from, cremaster was not in the option. Remember, this cremaster muscle itself is derived from internal oblique. So option would be either cremaster or internal oblique. Cremaster or internal oblique. Third, internal spermatic fascia. Internal spermatic fascia derived from fascia transversalis. Internal spermatic fascia is derived from fascia transversalis. Tunica vaginalis. Derived from peritoneum. Tunica. Tunicus is covering, sir. Tunica is covering. Tunica vaginalis is derived from peritoneum. Tunica albuginea. Tunica albuginea is derived from connective tissue. It's a connective tissue covering. Derived from connective tissue. Conjoint tendons formed by internal oblique and transverse abdominis. And the last one is tunica vasculosa. It's a vascular covering. Derived from vascular, so derived from blood vessels. Okay, so that's about the coverings of testes. Easy. Next, contents of inguinal canal. Contents of inguinal canal, you know, spermatic cord, ilioinguinal nerve in males. In females, it's the round ligament of uterus and the ilioinguinal nerve. What I want you to know is, what are the contents of spermatic cord? Abdomen has to distend, so no deep fascia there. If there's a deep fascia, it is very tensed. Contents of spermatic cord. Another very important MCQ. Contents of spermatic cord. 1. Vas difference. Vas difference. Second, artery to the vas. Artery to the vas. Superficial and deep rings are very easy. Superficial ring is a opening in external oblique aponeurosis. Deep ring is a defect in fascia transversalis. That's easy. Deep ring is a defect in fascia transversalis. Superficial inguinal ring is a opening in external oblique aponeurosis. Artery to the vas is a branch of superior vesical artery. Superior vesical artery. Artery to the vas is a branch of superior vesical artery. Okay, just one moment. Deep fascia is not there in the abdomen because the abdomen has to distend. Wherever there's a deep fascia, no, it forms compartments. Like in the upper limb there are compartments, in the lower limb there are compartments, and these compartments are formed because of the deep fascia. Okay, so if there's a deep fascia in the abdomen would not distend then, no? Okay, clear to all of you? Tunica albuginea, A-L-B-U-G-E-N-I-A, derived from peritoneum. Tunica vaginalis is derived from peritoneum. This is peritoneum. So there's a thick superficial fascia, no? Superficial fascia. Cremastic fascia is derived from cremaster or internal oblique. Is this clear to all of you? Okay, I'm starting with contents of spermatic cord. One is vas difference, second is artery to the vas, and this artery to the vas is a branch of superior vesical artery. If you can just tell me, the superior vesical artery is going to supply what? Vesicle. Vesicle meaning bladder. Fine. So superior vesical artery is going to supply the bladder. This superior vesical artery would be a branch of what? If you can just tell me. Bladder is in the pelvis. And I told you there's only one artery within the pelvis. There's only one artery within the pelvis. Who's that? Internal iliac. So all the organs inside the pelvis would be supplied by whom? Internal iliac. Meaning superior vesical artery would be a branch of internal iliac. Okay. And this superior vesical artery would give an artery to the vas. Third, cremasteric artery. Cremasteric artery. Cremasteric artery is a branch of inferior epigastric. Cremasteric artery is a branch of inferior epigastric. Cremasteric artery is a branch of inferior epigastric artery. And this inferior epigastric artery itself is a branch of what? This inferior epigastric artery itself is a branch of external iliac. Don't forget this inferior epigastric artery, it's very important. It's a branch of external iliac. So vas difference, artery to the vas, cremasteric artery, testicular artery. Testicular artery is a branch of abdominal aorta. You know, we've written gonadal vessels, gonadal artery. Gonadal artery is a branch of, gonadal vessels are branches of abdominal aorta. I remember gonadal artery. So in males it is testicular and females it would be ovarian. So testicular artery is a branch of abdominal aorta. Fifth, pampiniform plexus of veins. Pampiniform plexus of veins. Genital branch of genitofemoral nerve. There's nothing, retroduodenal part of bile duct, there's nothing posterior. You know why? Because the bile duct enters into the head of the pancreas. So there's no posterior relation. It's only anterior and then it enters inside the head. There's no posterior relation. Okay. So genital branch of genitofemoral nerve. Seventh is lymphatics from the testis. Lymphatics from the testis. Genital branch of genitofemoral nerve. Clear to all of you? This is genitofemoral nerve and genitofemoral. Okay, so that becomes the contents of spermatic cord. You're clear? Contents of spermatic cord. Okay. Clear to all of you? Contents of spermatic cord. One is the vas difference, second is artery to the vas, third is cremasteric artery, fourth is testicular artery, fifth is that plexus of veins, the pampiniform plexus of veins, the sixth is the genital branch of genitofemoral nerve, and the seventh is lymphatics from the testis. All these things are put together, all these things are tied together, and this becomes the spermatic cord. Spermatic cord. Clear to all of you? Okay, so that's about the anterior abdominal wall. Now understand something very important that I'm telling you. Have a look at this. These are very easy topics, just understand them. Okay, look, this is the rectus abdominis. Rectus abdominis. Contents of inguinal canal is clear, no? Inguinal ligament, you know what is inguinal ligament? Inguinal ligament is between the anterior superior spine and the pubic tubercle. So it's there. Okay, I'll start it here. Now don't ask questions, just have a look here. This is the pubic symphysis. That's the pubic symphysis. This is the rectus abdominis. That's the inguinal ligament. That's the superficial ring. That's the deep ring. I'm making this as the inguinal canal. And if you can just tell me, what is this artery? What is this artery here? Now this is very important. Just try to understand what is this artery here. This is the inferior epigastric artery. Okay. Okay, I'll start now. Look, this is the rectus abdominis. This is the rectus abdominis. This is the inguinal canal. That's a superficial ring, and that's a deep ring. This is the inferior epigastric artery, inferior epigastric artery. Now listen here. Just listen now. Do not write anything. You finish everything and then I start. Otherwise you sit and ask and then you don't concentrate. Now what I'm telling you is very important. Just have a look. Understand this. Artery to the vas is a branch of superior vesical artery. Artery to the vas is a branch of superior vesicle. Artery to the vas is a branch of superior vesicle. Now listen here, don't sit and type anything, just have a look. I'll start. This is the rectus abdominis here. That's a superficial ring here. That's a deep ring here. This is the inferior epigastric artery. Okay, understand now what I'm telling you now is very important. Concentrate. Okay, I'll start. What is this triangle known as? This triangle is known as the Hasselbalch's triangle. You know this? So rectus abdominis, inguinal ligament and inferior epigastric artery. This triangle is known as Hasselbalch's triangle. A hernia coming from here, is known as a direct hernia. And if a hernia comes to the deep ring, enters the inguinal canal and gets out through the superficial ring. What is this hernia? This is an indirect hernia. This you must be knowing. I'm just telling you something which you may not be knowing. Okay, look, a hernia which comes from the deep ring, enters the deep ring, inguinal canal and gets out through the superficial ring. This is an indirect inguinal hernia. And if a hernia gets out through this Hasselbalch's triangle, that's a direct inguinal hernia. Okay, now this Hasselbalch's triangle is further divided into two parts. Hasselbalch's triangle is further divided into two parts by, this is something which is known as the, yes, what is this known as? Obliterated umbilical artery. Obliterated umbilical artery, or this is known as the medial umbilical ligament. Medial umbilical ligament. What is the obliterated umbilical artery? What gets obliterated? I'll tell you later. So this is the obliterated umbilical artery or the medial umbilical ligament. This divides the Hasselbalch's triangle into two parts. Okay, if a hernia comes from here, one moment. If a hernia comes from here, this is known as lateral direct hernia, lateral direct. And if a hernia comes from here, it is known as a medial direct. Medial direct and lateral direct hernia. Now what is this medial direct? What is this lateral direct hernia? Just try to understand this. Be clear with your concepts now. Not urethus. Urethus is something different. Urethus is the median umbilical ligament. That's urethus. This is the medial umbilical ligament. Urethus is median umbilical ligament. I have to tell you that. Okay, just wait. Draw the slide. So this is the rectus abdominis. This is the rectus. That's the inferior epigastric artery. This is the obliterated umbilical artery, or that is the medial umbilical ligament. A hernia coming from here would be known as lateral direct. A hernia coming from here is known as medial direct inguinal hernia. Is this clear to all of you? Okay. Now see the slide and understand this. See the slide. Just get oriented to the slides. Tell me now, what is this view? Chill, see this view. What is this view? Where are you looking this from? Don't sit and ask me things. Just wait, I told you. Don't keep on asking things. Just concentrate on what I'm telling and be with me. Okay. Tell me, what is this view? Where are you looking this from and what are you looking at? Which wall of the abdomen is this? Which wall of the abdomen is this? This is the anterior wall of abdomen. You're looking from inside the abdomen. Anterior wall of abdomen, you're looking from inside the abdomen. Now tell me, what is this? I'll be telling you everything. I just give a reference. If I've told you once, that means I've just given a reference. Details we'll be discussing later. So just concentrate. What is this that I'm showing you? This is the falciform ligament. Falciform ligament. This is the anterior abdominal wall. We're looking from inside. You remember the previous slide I had shown you? A sickle-shaped fold of peritoneum which comes from the anterior abdominal wall to the lever. What was that sickle-shaped fold of peritoneum from the anterior abdominal wall to the lever? Falciform ligament. Now this you're looking from inside. We've removed the lever and this is the falciform ligament. Okay. And what is this? What is this within the falciform ligament? This is the ligamentum teres. Ligamentum teres. Okay. So this ligamentum teres is present within the falciform ligament. Don't get confused. I'll be telling you this later. I'm just showing you what is seen in the slide. Okay. Look, this is so nice. You tell me, what is this going to be? That's a diaphragm. That's a diaphragm. And tell me now, who's this and who's this? Chalo, answer now. That's a diaphragm that I've shown you. What's this and what are these two arrows that are pointed? What is this, you tell me? This. What is this, the artery I'm showing you? I'm not showing you falciform ligament. What is this that I'm pointing you? This is an artery. And this is the superior epigastric artery. You understanding? This superior epigastric artery has come in the abdomen here. And if that's the superior epigastric artery, what is this opening in the diaphragm? This is what I was telling you. This opening is in the diaphragm is the foramen of Morgagni. Foramen of Morgagni on the space of Larry. And this superior epigastric artery from the thorax would enter into the abdomen through this gap here. That's the foramen of Morgagni on the space of Larry. And this superior epigastric artery is going to anastomose with, what's this going to be? Inferior epigastric artery. And this inferior epigastric artery is a branch of, what's this? External iliac. Okay. This inferior epigastric artery is a branch of external iliac. You're clear? Don't get confused now. Now things will be slightly confusing. Just be with me. Clear? So there's an anastomosis between the superior and inferior epigastric artery. The superior epigastric artery is a branch of internal thoracic and the inferior epigastric artery is a branch of external iliac. Clear? And this inferior epigastric artery gives a branch. I just told you that branch. If you remember, a branch of inferior epigastric artery is cremasteric artery. So now things will be diversified here. Branch of inferior epigastric artery is cremasteric artery. Just try to correlate. Okay, fine. Clear? Now, look at this now. What is this? This is the urinary bladder. That's the urinary bladder. And I told you, in fetal life, from the apex of the bladder to the umbilicus, there's a communication from the bladder to the umbilicus. And this is what we call as urachus. After birth, this communication is gone. And this becomes a ligament in us. A ligament which begins from the apex of the bladder to the umbilicus, and this is what we call as the median umbilical ligament. So median umbilical ligament is the obliterated urachus or allantois. You clear? If this urachus does not obliterate, the child will be passing urine through the umbilicus, and this is what we call as weeping umbilicus, crying umbilicus. So weeping umbilicus is due to persistent of urachus. Fine. Now, so that's the median umbilical ligament. Go slightly lateral to it. Go slightly lateral. You find one more ligament here, and this is what we call as the medial umbilical ligament. And this medial umbilical ligament is the obliterated umbilical artery. I just told you this. Obliterated umbilical artery. What is umbilical artery? What gets obliterated? I'll tell you later. So medial umbilical ligament is the obliterated umbilical artery. Fine, fine. And go further lateral, go still lateral. You find one more ligament here, and this is what we call as the lateral umbilical ligament. But this is not an actual ligament. This is not a true ligament. This is just a fold of peritoneum. A fold of peritoneum which covers the inferior epigastric vessels. It's just a covering, a fold of peritoneum which covers the inferior epigastric vessels. Yeah. So we'll just write this down first. These are very important things. You should be knowing all these things, right? Have a look here. What is medial, medial and lateral? Have a look. Starting with median umbilical ligament. So once you understand this one, you'll understand all those hernias and all. Median umbilical ligament. Median umbilical ligament is the obliterated urachus on allantois. Median umbilical ligament is the obliterated urachus or allantois. If it does not obliterate, that's weeping umbilicus. If it does not obliterate, it is known as the weeping umbilicus. So that's median umbilical ligament. Second, medial umbilical ligament. Medial umbilical ligament. That is the obliterated umbilical artery. Obliterated umbilical artery, lateral umbilical ligament. Lateral umbilical ligament is a fold of peritoneum which covers inferior epigastric vessels. It's a fold of peritoneum which covers the inferior epigastric vessels. The same, that is urachal fistula. Same and a weeping umbilicus is urachal fistula only. Urachal fistula. So be clear about this. So medial and lateral umbilical ligament. So weeping umbilicus is urachal fistula. Same. Now see the slide once again and just try to understand. Just be clear with your concepts. Okay. Once again, coming back to the slide. I'll start and just have a look. Now tell me, what is this? This is the median umbilical ligament. Or there was a muscle right here inside. What was that? Rectus abdominis. It's not seen, muscle is outside, rectus abdominis. Okay, we are not able to see that, but I've just drawn that muscle for you. Rectus abdominis here. What is this? This is the inferior epigastric artery, and that's the inguinal ligament. Fine now. What is this triangle here? This is the Hasselbalch's triangle. There would be the rectus abdominis here. I can't show you that because that's outside. So that's the rectus abdominis, that's the inferior epigastric artery, and that's the inguinal ligament. So what's this now? Hasselbalch's triangle. And this Hasselbalch's triangle is further divided into two parts by, what is this now? This is the obliterated umbilical artery. So if a hernia is going from here, what is this hernia known as? This is a lateral direct, and if a hernia gets out from here, this is a medial direct hernia. Lateral direct and medial direct. And now, what is this? What is this opening here? What is this ring here? You can understand this. This is the inferior epigastric artery here. And what is this ring? That's a deep inguinal ring. So if a hernia gets out through the deep ring, what is that hernia known as? Indirect. And if the hernia gets out through this Hasselbalch's triangle, what is this known as? Direct hernia. You're following? You're clear? Now see, understand what I'm telling you now is very important. Have a look here. Now, tell me, if a hernia gets out through this deep ring, where is the hernia? Where is the hernia now? It's right inside the inguinal canal. And from the inguinal canal, it gets out through the superficial ring, it enters the scrotum. That's an indirect hernia. Following this? If a hernia gets out through the deep ring, if a hernia gets out through the deep ring like this, that's an indirect hernia. The indirect hernia is right inside the inguinal canal, and from the inguinal canal through the superficial ring, it enters the scrotum. Fine, that's it. Now tell me, if a hernia gets out from here, what is this hernia? A direct hernia. And tell me now, if a hernia gets out from here, where is the hernia now? Where will the hernia be? If a hernia gets out from here, it gets out from here. Where is the hernia? Answer this. If a hernia gets out from here, where is the hernia now? Chalo, bolo fast. Gets out from here. Where is the hernia? Abdomen. We are in the abdomen only. Where is the hernia? If a hernia gets out from here, where is the hernia? Yes, answer. I'm looking what you are answering. Abdomen. We are in the abdomen only. Now where else to go in the abdomen? Yes. Look. If a hernia gets out from here, look here once again. If a hernia gets out through the deep ring, hernia is getting out through the deep ring. The hernia is inside the inguinal canal. Then it will go through the inguinal canal and get out through the superficial ring into the scrotum. That's an indirect. Now what I'm telling you is, if a hernia gets out through this triangle, if a hernia gets out from here, the hernia is right inside the inguinal canal. It's right inside the inguinal canal. You're following this. What is this that we're looking? This is the anterior abdominal wall. That means, who's this in front here? Who's this here? This is the inguinal canal. We are looking at the posterior wall of the inguinal canal. That means, what is the hernia doing? It is breaking the posterior wall of the inguinal canal, and it is going right inside the inguinal canal. It is therefore known as a direct hernia. You're following this? It's right inside the inguinal canal. It's right in the inguinal canal. Look, no, what is this? This is the anterior abdominal wall. Who's right in front here? That's the inguinal canal. No, that means what is this that we're looking at? We're looking at the inguinal canal, the posterior wall of inguinal canal. No, this is the fascia transversalis. So this is the posterior wall of inguinal canal. So if a hernia is getting out from here, what is the hernia actually breaking? It is breaking the posterior wall of inguinal canal and directly enters inside the inguinal canal, and that is why it is known as a direct hernia. Is this clear? Yes, yes, yes. So if a hernia gets out from here, it's a lateral direct, and if a hernia gets out from here, it's a medial direct inguinal hernia. Okay, so this is what I want you to understand. Now, clear? Now have a look at this. Now there's something here. This is a fossa here, this is a fossa here, and this is a fossa here. You have to know what are these fossae and which hernia gets out through which fossa. Okay, so which hernia gets out through which fossa? See, my job is to clear your concept. The rest of the things you'll understand in surgery. Your concept should be clear. Now have a look and understand this. Look, this is so nice. Just try to understand this. You know, this starts from the beginning. That is the problem. Okay, start. Look at this now. Look, this is so nice. Just try to understand this. Okay, I start here. Tell me now, what is this that I've drawn for you? And when I'm telling you, just concentrate. Don't write anything. Just concentrate. Look, who's this? Don't draw anything. I'll give you time for this. This. Who's this? Who's this here? No, 8 meter. And who's this here? Keep on changing the colors. Who's this and this and this? Chalo bolo. What are these? What have we drawn? What are these dots? These are the umbilical ligaments. This is the median umbilical ligament, that's the medial umbilical ligament, and that's the lateral umbilical ligament. This is just a diagrammatic representation for you. Okay, that's a median, medial, and lateral umbilical ligament. Look, like, just listen here now. Listen, concentrate. Like, you know, you've got 5 ropes like this. You've got 5 big long ropes, and you have a long cloth to dry. You put a long cloth to dry. 5 ropes here, and you put a long cloth to dry. The cloth doesn't remain like this. The cloth goes down, comes up, again goes down, comes up, like this, like this. Similarly, these are the 5 ligaments. What's that? The medial, and the lateral umbilical ligament. And who's going to cover this ligament? The peritoneum. And the peritoneum will go down, it will come up, again go down, come up. Like this, it forms fossae, fossa. You have to know what are these fossae and which hernia gets out through what fossa. This is extremely important. Just try to understand this and then you draw. Do not draw anything, you'll not understand otherwise. Okay, I'll start. Have a look at this and you tell me now. Now, the peritoneum goes down, comes up, again goes down, comes up, again goes down. And now you tell me, where are we going? Where are we going now? Where are we going? You're on the lateral walls of the abdomen, lateral abdominal wall. Again, the peritoneum goes down, comes up, again goes down, comes up, and now it goes on the lateral abdominal wall, lateral walls of the abdomen. Okay, don't draw this, just wait. I'll give you time for this. Understand first. Now, I'll make this as the rectus abdominis. Rectus abdominis will not be seen from inside, but I'm just making this for our understanding. Okay, what is this artery here? What is this artery here? That's the inferior epigastric artery. Okay, and what was this? What was this? This was the medial umbilical ligament. Okay, so what is this fossa known as? Just one moment, I have to keep changing colors here. What is this fossa known as? Here, who's this bladder? So this is the supravesical fossa. Supravesical fossa. This is the medial inguinal fossa, and this is the lateral inguinal fossa. Just wait, understand this first. So now you've got three fossae. One is the supravesical, one is the medial inguinal, one is the lateral inguinal fossa. And look, this is so nice. Now you tell me, if a hernia gets out from here, what is this ring here? That's a deep inguinal ring. If a hernia gets out through this deep ring, what is that hernia? Indirect inguinal hernia. So what I want you to understand is an indirect inguinal hernia will get out through which fossa? Lateral inguinal fossa. Okay. If a hernia gets out from here, what is this hernia? Direct. What is this? Lateral direct, and that's medial direct. A lateral direct inguinal hernia will get out through which fossa? Medial inguinal fossa. And a medial direct inguinal hernia will get out through the supravesical fossa. Am I clear to all of you? This is what you're supposed to know. Okay, finish the slide. That's it. You'll understand. Just draw this. You'll understand. Fossa is from where the hernia goes. Fossa is just a peritoneal fold. To go in the inguinal canal, it has to break the wall of the inguinal canal. No, fossa is just a fold of peritoneum. Remember that. This is just a diagrammatic representation. This is not a view. This is just a diagrammatic representation. Indirect hernia gets out through this superficial ring. To go into the superficial ring, it has to first go in the inguinal canal. No. This is anterior abdominal wall from inside. Okay, that we can say. Anterior abdominal wall from inside. See, these are the folds of peritoneum inside the abdomen. These are the fossae inside the abdomen. So the hernia will take support of this fossa, but the hernia has to enter into the inguinal canal. No. So to enter the inguinal canal, it has to break the inguinal canal. It has to break the posterior wall of the inguinal canal. Only then it goes into the inguinal canal. Understanding this, these fossae are inside the abdomen. They are just folds, and the hernia will be taking support of this fossa and going. It's like that. Clear to all of you? Okay, I'll explain this once again. It will be clear. So this I have written as indirect, this I have written as lateral direct, and this I have written as medial direct. This should be clear and be very strong with your concepts. MCQs you'll be able to answer. Because the same MCQs will be repeated in different ways. The concept is going to be the same. What is the artery? Artery is inferior epigastric artery. We have drawn this slide before. We have drawn the slide. I've just drawn the same slide again. Direct hernia doesn't reach till the superficial ring, and indirect hernia goes till the superficial ring. Direct hernia doesn't reach the superficial ring. These details you will understand in surgery. They will tell you. Clear to all of you? Indirect hernia goes till the superficial ring, enters the scrotum. Direct hernia doesn't reach till the superficial ring. Okay. Okay, you'll understand it. Just have a look at this slide. Done with the drawing part? Look, once again, see the slide, and this is a very important slide, because in any slide of anterior abdominal wall, you are going to see this ligaments, or you have to be perfect with all these ligaments. Any slide of anterior abdominal wall, you are going to see all these ligaments. Have a look. I'll start once again. Just concentrate now. If you've not understood, once again, look, I'll start. This is a view of anterior abdominal wall from inside the abdomen. This is the median umbilical ligament. That's the median umbilical. Now don't sit and type anything, just concentrate. That's the median umbilical ligament, that's the medial umbilical ligament, and that's the lateral umbilical ligament. What is this fossa here? That's the supravesical fossa. This is the medial inguinal fossa, and that's the lateral inguinal fossa. Okay, now what is this ring here? That's a deep ring. Now tell me, a hernia getting out through this deep ring is indirect inguinal hernia. That means an indirect inguinal hernia is getting out through which fossa? A lateral inguinal fossa. What is this triangle? Hasselbalch's triangle, divided into two parts by the obliquated umbilical artery. A hernia getting out through this is known as a lateral direct. A hernia going out from here is known as medial direct hernia. So a lateral direct inguinal hernia will get out through which fossa? Which fossa? That's the medial inguinal fossa, and the medial direct inguinal hernia will get out through the supravesical fossa. Am I clear to all of you? It should be perfect. Look, this is so nice. Look, what have we done here? Okay, now clear to all of you? Yes, that's it. That's the concept. You understood this. Now see, what have we done here? We've taken the anterior abdominal wall down. I'm telling you again and again, in all the slides of anterior abdominal wall that you're going to see these 5 ligaments always. So be very perfect with this. Okay, we've taken the anterior abdominal wall down, and look at this now. Look at this. Who's this? This is the median umbilical ligament. This is the medial umbilical ligament, and that's the lateral umbilical ligament. Okay. Now we've taken the anterior abdominal wall down like this. So all these ligaments are sticking here. They are sticking here to the anterior abdominal wall. If I take this and if I place this back like this, I'll be getting fossae here. Fossae. Those fossae you'll not be able to appreciate in this slide, because we've taken the anterior abdominal wall down. All this is sticking to the anterior abdominal wall. So what will this fossa here be? This fossa, supravesical, here will be medial inguinal, and here would be lateral inguinal fossa. Okay, one more slide I'll show you. So that would be, see this is a very good slide. You tell me, what is this view? Where are you looking this from? Indirect comes out through the superficial deep ring. Break 230. Break is at 230. Okay, have a look at the slide. This is, we're looking inside the abdomen from above. Inside. We're looking from above. So what is this? Bladder. This is the uterus, and this is the rectum. Bladder, uterus, rectum. Look, this is nice. What is this now? What is this? This is the median umbilical ligament. What's that? Medial umbilical ligament. And what's that? Lateral umbilical ligament. You're following now? Now, what is this? Fossa. See this depression here. See this depression. This is the supravesical. See this depression here. This is the medial inguinal. And see this depression here. That's the lateral inguinal fossa. Clear? What is this ring? The deep inguinal ring. And hernia getting out from here would be known as indirect inguinal hernia. Gets out through which fossa? Lateral inguinal fossa. A hernia getting out from here, that is a lateral direct hernia, gets out through medial inguinal fossa. And a hernia getting out from here, that's a medial direct through the supravesical fossa. We should be clear to all of you. Okay, that completes my anterior abdominal wall. So is this clear to all of you? Yes. Now understand this. Peritoneum now. Peritoneum. Before I start with the peritoneum, I need to give you an orientation to the organs. Get an orientation to the organs, you will understand the peritoneum very well. Okay? Have a look. I'll start. Clear to all of you? Yes? Following? Enjoying? Okay, I start. Okay, I'm starting the peritoneum. To understand the peritoneum, I have to give an orientation to the organs. Okay, I'll just give an orientation to the organs, see how the organs are placed inside the abdomen, and then we start with a peritoneal reflection. It's very nice to understand the peritoneum. Okay, I start. Starting with posterior relations of the kidneys. Now this, everything you know, I just have to put this on the paper, have a look at this. I'll start. The posterior relations of the kidneys. And look, this is so nice. You know everything. Tell me the first muscle here. Posterior relations of the kidneys. Do not draw. Please do not draw. Just understand this first. That's the psoas major. Psoas major. What is the second muscle? Quadratus lumborum. And what's the third muscle? Transverse abdominis. The psoas major, the quadratus lumborum, and the transverse abdominis. Okay. What is this? And what is this? This is the medial arcuate ligament, and that's the lateral arcuate ligament. Medial and lateral arcuate ligament. And now you get nerves here. What are these nerves? What is this nerve? This is the subcostal. This is the iliohypogastric, and that's the ilioinguinal nerve. Okay, subcostal, iliohypogastric, and ilioinguinal nerve. So all this becomes the posterior relations of the kidneys. This is a very important MCQ also. While exposing the kidney from a posterior aspect, all the following structures will be encountered except. Okay, starting with this, posterior relations of the kidneys. Understand this now? Posterior relations of the kidneys. Posterior relations of the kidneys. That's the psoas major. That's the quadratus lumborum. That's the transverse abdominis. Psoas major, quadratus lumborum, transverse abdominis. This is the medial arcuate ligament. That's the lateral arcuate ligament. That's the subcostal. Iliohypogastric. Ilioinguinal nerve. Genitofemoral nerve lies on the medial aspect of psoas major. It's on the medial aspect. So genitofemoral nerve doesn't come here. The entire psoas major doesn't come here. A part of psoas major, the lateral part of psoas major is related to the kidney. Whereas the genitofemoral nerve is more on the medial side. So we don't take genitofemoral nerve. Okay. So the posterior relations of the kidney from medial to lateral. This is psoas major, this is quadratus lumborum, this is transverse abdominis. Psoas major, quadratus lumborum, transverse abdominis, the medial arcuate and lateral arcuate ligament, the subcostal, the iliohypogastric, and the ilioinguinal nerves. And you tell me, which kidney is this? This is the, if I make this as left kidney for you, left kidney, there will be two ribs which are related to the left kidney. Which are those two ribs? One is the, which kidney is lower, you tell me, which kidney is lower? The right kidney is lower because of the lever. The right kidney is lower, so the right kidney would be related only to the last rib, number 12. The left kidney is higher, so the left kidney would be related to the last two ribs, 11th and 12th. So I'll just make this as 11th rib and I make this as a 12th rib. 11th and 12th ribs. Only one difference, the right kidney and the left kidney, everything is the same, only the right kidney would be related to 12th rib, remember. And the left kidney would be related to 11th and 12th rib. This is clear to all of you? Rectus sheath, I'll tell you. Rectus sheath, I'll tell you. Okay, clear? So 11th and the 12th rib. Clear? I'll clear this. Done? So this is the left kidney. Right kidney, only one difference, 12th rib. Rest everything is the same. 11th rib is not there for the right kidney. Okay, understand the anterior relations of the kidney now. Anterior relations of the kidney. Anterior relations of both the kidneys. Just understand this now. Tell me now, who's here? Who's here? The suprarenal gland. Don't draw this. That's a suprarenal gland. Okay, related anteriorly to the kidneys. Now, tell me, what is this structure that I'm drawing here? What is this here? The right kidney is anteriorly related to what? The second part of duodenum. Second part of duodenum, the C. So the right kidney is anteriorly related to the second part of duodenum. Okay. So posterior relation of second part of duodenum is going to be what? The right kidney. Okay. If the anterior relation of right kidney is the second part of duodenum, the posterior relation of second part of duodenum will be what? Right kidney. If that's the duodenum, you tell me what is this going to be? If that's the duodenum, C of the duodenum, this is going to be the pancreas. If that's the pancreas, what is this structure going to be? The spleen. That's the pancreas and that's the spleen. If that's this pancreas and that's the spleen, what is this artery on the superior border of the body of pancreas? That's the splenic artery. Splenic artery. Okay. This would be the splenic artery. There's a big organ on this side. Name this organ. 1 minute. What is this big organ here on the right side? The big organ here would be the liver, like this. The liver. So that is going to be the liver. And tell me, there's someone who's going to ascend up. Someone who's going to ascend up. What's this? Ascending colon. Ascending colon. And there's a bend here. What's this bend? A bend is known as a flexure. This is the liver, so that's a hepatic flexure. I'm not drawing this. Who's this? Who's this? Transverse colon. I'm not drawing that transverse colon. Otherwise, everything gets covered here. What is this bend here? Splenic flexure. And what is this now? Descending colon. That's the descending colon. And there's something else that you get here. What are these? This, like this, like this, like this, like this. These are the small intestines. Small intestines. Don't draw this. Just listen. These are the coils of small intestines. So now, see the relations here. One moment. See the relations. Anterior relations of right kidney. Just one moment. Don't draw anything. Anterior relations of right kidney. 1 is the liver. Second is the suprarenal gland. Third is the second part of duodenum. Next is the ascending colon and the hepatic flexure of colon and the small intestines. Small intestines. So the right kidney would be anteriorly related to the liver, the second part of duodenum, the ascending colon and the hepatic flexure and the small intestines. The left kidney would be anteriorly related to, you're following all this? The left kidney would be anteriorly related to, one, the left suprarenal, the spleen, the left suprarenal, the spleen, the splenic artery, the pancreas, the splenic flexure of the colon and the small intestines. Clear? So the left kidney would be related to 1, the left suprarenal gland, the spleen, the splenic artery, the splenic flexure and the descending colon and the small intestines. Okay, and we just place an organ here. See, one moment, let me finish this, then you draw. Now we just place an organ here. What is this organ going to be? One moment. Okay, we just place an organ like this and like this. What is this organ going to be? That's going to be the stomach. This is going to be the stomach like this, and all this is going to form what for the stomach? All this will be forming what? The posterior relations of the stomach. Posterior relation of stomach. So this part of the kidney would be related to what? Stomach. And this entire thing is going to form the stomach bed. Okay, so now once again you tell me, what is the anterior relation of left kidney? Here, the left suprarenal, the stomach, the spleen, the splenic artery, the pancreas, the splenic flexure and the descending colon and the small intestines. Now what is the stomach bed formed by? Stomach bed. The stomach bed, will be writing all these things. Just listen. The stomach bed is formed by 1, the left suprarenal, the left kidney, the spleen, the splenic artery, the pancreas, the transverse colon. Okay, this is going to form the stomach bed. And what is this? If you can just tell me, what is this that I'm drawing? This is the left crus of the diaphragm. Left crus of the diaphragm. This forms the stomach bed. Okay, just draw the slide. Draw this line. I'll tell you all these things. I'll tell you. Just draw this line. Just remember all these lines. Things will be easy to understand. Yes, draw this. You draw this now, you'll remember that. One moment. Following now. Once the structures are clear now, they are behind the pancreas now. They will join behind the pancreas. That notes superior mesenteric vein is medial. Is medial. I'll show you the slide. We'll be writing this. Just wait. Namings. I'll write that. I'll write that. You just draw that. I'll write that. Okay, done. Understand now. Starting with right kidney. Right kidney, anterior relation. I'll write that. 1. Right suprarenal. You get MCQs on this one. The right kidney is anteriorly related to all except. The left kidney is anteriorly related to all except. So you have to know this. The lever. Second part of duodenum. Second part of duodenum, ascending colon and hepatic flexure. Ascending colon and hepatic flexure. Small intestine. Clear? So the right suprarenal, the lever, the second part of duodenum, ascending colon and hepatic flexure, the small intestines. Left kidney. You understand the left kidney, you will understand the stomach bed also. Once you understand the left kidney, you will understand the stomach bed also. So just tell me one thing. Orange color is pancreas. Orange is pancreas. Orange color thing is pancreas. Pancreas. And these are the small intestines. Clear to all of you, know? Pancreas and small intestines. Okay. Now just one thing. You see this is the second part of duodenum. What is the posterior relation of second part of duodenum? Chalo bolo fast. What is the posterior relation of second part of duodenum? Just see the slide. The second part of duodenum is lying on the right kidney. So the posterior relation of second part of duodenum is going to be right kidney. It's going to be right kidney. Okay, second part of duodenum ka posterior relation is right kidney. And who's crossing the second part of duodenum in front? If you can answer that. There's someone who's crossing the second part of duodenum in front. What is this in green? In green, who's this? I've not drawn the entire structure. That's the transverse colon. So who's crossing the second part of the duodenum in front? And that's the transverse colon. And the transverse colon is crossing the entire pancreas. That means the entire pancreas anteriorly would be related to transverse colon. The second part of the duodenum is anteriorly related to transverse colon. You following this? You following this? Yes? Is this clear? So now you tell me, what are the relations of the second part of the duodenum? Anterior relation is the transverse colon, posterior relation is the right kidney. And now you know the first part of the duodenum, you know the second part of the duodenum. Okay, quickly, if you can just recapitulate. Okay, tell me, relations of the duodenum, the first part of the duodenum. You remember the first part of the duodenum? First part of the duodenum. Tell me, the first part of the duodenum, anterior relation. Quickly, just recapitulation first. The first part of the duodenum का posterior relation. चलो बोलो first. Answer. First part of the duodenum is posteriorly related to what? 1. The bile duct. 2nd, the gastroduodenal artery. And 3rd was the portal vein. Remembering the first part of the duodenum, posterior relation. The bile duct, the gastroduodenal artery and the portal vein. And the first part of the duodenum, anterior relation. You remember that slide? The lever up and the gallbladder there. And you put the slide back. The body of the gallbladder lies over the first part of duodenum. So first part of the duodenum ka anterior relation is going to be the body of the gallbladder. First part of the duodenum ka posterior relation is going to be the bile duct, the gastroduodenal artery and the portal vein. The second part of the duodenum, the posterior relation is going to be the right kidney and the anterior relation is going to be the transverse colon. So you should be clear with the first and the second part of the duodenum. I am left with the third and the fourth part. So automatically now you know the duodenum. Okay, clear to all of you. So now just finish this. Left kidney ka anterior relation. So this is how you correlate the relations of the organs. Then it is easy. Left kidney, start. 1. Left suprarenal. Again, duodenum we have not started at duodenum. I'm here to come to the topic, but what I'm telling you is, before we come to the duodenum, you'll be knowing the entire duodenum. Before we come to the pancreas, you will be knowing the entire pancreas. So it is very easy to correlate like that. Okay, so 1, left suprarenal. Left suprarenal. 2nd, stomach, spleen, splenic artery, pancreas, splenic flexure, kidney. Left kidney would be related to the splenic vein. You can take this as splenic vein also. Splenic vein. That's fine. Splenic vein would be related to the kidney. Pancreas. Then splenic flexure. And descending colon. Small intestine. Kidney is a retroperitoneal organ. Pancreas is also a retroperitoneal organ. Pancreas is also a retroperitoneal organ. Wait, no. That only I'm telling you. I have to tell you the peritoneum. No, for all this I'm telling you this. Wait, no, you'll understand. Peritoneum. Peritoneum is a very nice topic. Left suprarenal. By this you should be able to understand the labelings. Left suprarenal, stomach, spleen, splenic artery, pancreas, splenic flexure, descending colon, small intestines. If you know this, you will understand the stomach bed, because what lies on this is the stomach. So you will be understanding the stomach bed. Stomach bed. Stomach bed will be formed by left kidney, left suprarenal, body of the pancreas. That's right. Left kidney, left suprarenal, splenic artery, left kidney, left suprarenal, splenic artery, spleen, wait one moment, spleen, pancreas. Transverse colon will not be related to the kidney because transverse colon is in front of the pancreas, okay, but transverse colon will be forming the stomach bed. Remember, transverse colon is in front of the pancreas. It's front and it's slightly below the pancreas. So in anterior relation of kidney, transverse colon does not come, but in stomach bed the pancreas as well as the transverse colon comes. Okay, you're clear now? So pancreas, transverse colon. In kidney relation, no, transverse colon does not come. The splenic flexure comes. The splenic flexure and descending colon. You understanding this? That's the only difference there. In stomach, the transverse colon is related. To the kidney, the transverse colon is not related. The splenic flexure and the descending colon is related. And the last one is the left crus of the diaphragm. These are easy things. Don't get confused in this. Left crus of the diaphragm. So I've written everything. I have not missed transverse colon. I have not missed transverse colon. Transverse colon will be coming in stomach bed. Transverse colon does not related. Transverse colon is not related to the kidney. Understanding now? Head of the pancreas. No, that's the second part of duodenum comes there, no? Head of the pancreas is not much related to that. No, not much related. Clear to all of you? Okay. You understood the relations, you understood the stomach bed. Okay, now listen here now. These are easy things, don't get confused much. What I'm telling, just remember that. Now with this concept, understand the peritoneum. Okay, understand this peritoneum. This is difficult. I'm taking a sagittal section. Okay, now just before that, you see here, listen now. Do not write anything, don't write anything. Just concentrate here and understand. Yes. Okay, now listen here now. Listen. Now we open the anterior abdominal wall. Listen to this. We open the anterior abdominal wall, and the first thing that we see on the left side would be what? Stomach. On the right side, what do you see? The liver. The moment we open the anterior abdominal wall, on the left side would be what? Stomach. Okay. We lift the stomach, and who's behind the stomach? What's this behind the stomach? The moment you open the anterior abdominal wall, on the left side is the stomach. We lift the stomach. Who's behind the stomach? Who's this? Transverse colon. And you lift the transverse colon. Who's behind the transverse colon? Pancreas. You are able to follow this? So the first thing when we remove the anterior abdominal wall, on the left side is the stomach. We lift the stomach. Behind the stomach is the transverse colon, and we lift the transverse colon. Behind the transverse colon is going to be the pancreas. This should be clear. Okay, just see the side that you've drawn. It will be clear. So with this concept, understand the peritoneum. This is very important, the peritoneum. Okay, I'll start. I'll draw a sagittal section. I'm taking a section for you and I'm drawing a sagittal section for you. Have a look. Sagittal section of the abdomen. Here. This is the stomach. That's the stomach. Who's behind the stomach? Transverse colon. And who's behind the transverse colon? That's the pancreas. Okay, they are one behind the other. Stomach. Behind the stomach is transverse colon, and behind the transverse colon is the pancreas. Don't draw anything. Do not draw anything. Just concentrate. Okay, otherwise then you sit and ask doubts. Just concentrate. This is the stomach, this is the transverse colon, and that's the pancreas. Tell me, who's this behind the pancreas? Who's this behind the pancreas? This is the posterior abdominal wall. Behind the pancreas lies the posterior abdominal wall. What's this? This is a big organ here. This is a sagittal section. Liver be cut in any direction, it will look like that. That's the liver. And tell me now, what is this going to be? That's the diaphragm. Okay, that's the diaphragm here. This is the diaphragm. Okay, I'll start. Now, just have a look, understand this and be very clear. All the structures are clear. I'm taking a sagittal section. You're looking from the side. So that's the stomach, that's the transverse colon, that's the pancreas, this is the posterior abdominal wall, that's the liver, and this is the diaphragm. Okay, now we start. We begin from the liver. We come down. Who are we? Who are we? We are the lesser omentum. We begin from the liver and we come down. We are the lesser omentum. The lesser omentum comes to the stomach. Now splits. It splits over the stomach. It encloses the stomach. And now we are going down. We are going down. Who are we? Who are we? We are the greater omentum. The greater omentum goes down. It turns and it comes back like this. It goes back. It goes back. What is this structure? The transverse colon. The peritoneum splits, encloses the transverse colon. It encloses the transverse colon. Okay. And what is this peritoneum enclosing the transverse colon known as the transverse mesocolon? Transverse mesocolon. So now you tell me, the stomach, the transverse colon are completely enclosed by the peritoneum, and such organs which are completely enclosed by the peritoneum are known as intraperitoneal organs, and they move with respiration. Intraperitoneal organs, they move with respiration. Fine. Now the peritoneum comes to the pancreas, and look how nice. It splits over the pancreas. It divides over the pancreas. The pancreas goes behind the peritoneum, and such organs behind the peritoneum are known as the retroperitoneal organs. You're getting this? Now, a layer of the peritoneum will go over the posterior abdominal wall. It goes to the diaphragm. It goes to the diaphragm. It can't cross this because this part of the liver is fixed to the diaphragm. And what is that part of the liver which is fixed to the diaphragm known as the bare area of liver? It is fixed, no? It is the bare area. And so the peritoneum cannot cross this because the liver is fixed here. So what does the peritoneum do? The peritoneum gets reflected back and goes to the liver, and here it comes like this. And look how nice. What's this? What's this? This is the lesser sac. Okay, that's the lesser sac. And that's how the lesser sac is behind the stomach. Okay, clear to all of you? Now, I trace the second layer of peritoneum in a different color. Do not draw anything. Just wait. I'll give you time for all this. Okay, I'm tracing the second layer of peritoneum in a different color. Yep. Now, the second layer of peritoneum goes down, it covers the pancreas, it is going down, and here it goes to the posterior abdominal wall. And again, who's this? Who's this? The small intestine. So the peritoneum encloses the small intestine, and the peritoneum covering the small intestines is known as what? The mesentery. The peritoneum now goes on the posterior abdominal wall, gives an inverted V-shaped mesentery. An inverted V-shaped mesentery is known as what? An inverted V-shaped mesentery is for which organ? It's an organ who's an S-shaped. What's that? The sigmoid colon. And this mesentery of the sigmoid colon, which is an inverted V-shape, is known as the sigmoid mesocolon. Okay. The peritoneum now goes down. Where are we? We are in the pelvis now. The peritoneum now covers the rectum here, covers the bladder here, covers the uterus, and now covers the bladder here. And here we are in front. And here we go to the anterior abdominal wall, that's the umbilicus. And from the umbilicus we go straight up, we go to the diaphragm. We can't cross this, we come back to the liver. And look how nice, what is all this? All this is the greater sac. You following this? The greater sac, lesser sac. Understand how the greater sac, lesser sac is formed? And if you see this, there is a small opening here, there's a small foramen here, and this is the epiploid foramen. This becomes the epiploid foramen. Fine. So this is what I was telling you. What are the anterior boundaries of the epiploid foramen? I told you the portal vein, but remember, portal vein is not alone, no? Portal vein is along with its two structures, along with the other two structures, the hepatic artery and the bile duct, together present in that fold of peritoneum. What is that? Lesser omentum. So anterior boundary of epiploid foramen is going to be the lesser omentum containing hepatic artery, portal vein and bile duct. But suppose if I have to select one out of these three, Then I select it as portal vein. Okay. Is this clear to all of you? This is the entire slide. This is so nice, and you understand this, the entire peritoneal part will be clear to you. Okay, you draw this, plenty of labelings in the slide. I'll label this for you. Understand and draw. Okay, understand as you're drawing. Foramen of Winslow is epiploic foramen, no? Kidneys are retroperitoneal, no? Kidneys will be retroperitoneal. I'll show you that. Great omentum, this omentum. This is what we call as the rectouterine pouch, and this is what we call as the utrovesical pouch. That's the epiploic foramen. That's the Lesser sac. And that's the greater sac. That's a greater sac. You can't see the kidneys, no, in this slide. How can you see the kidneys in this slide? You tell me. That's a sagittal section. You're just passing right from the center. That's a sagittal section. So kidneys are on either sides. No, you will not see the kidneys in this slide. You are following this. It's a sagittal section. I'll show you the slide. Just wait. It's a sagittal section. So kidneys are on both the sides. If you take a section through one of the sides, a parasagittal section, you'll see the kidneys there. Understood now? Fine? Yes. Be clear with your concepts and try to have that three-dimensional imagination, three-dimensional view. Okay, clear? Now see the slides, it will be clear. If you have done, you tell me. Yes. Lesser and greater omentum because of that. Okay, if you have done, you tell me. There's one labeling left. BL. Bladder. R is rectum. R is rectum. This is rectum. This is uterus. UT is uterus and BL is bladder. Urinary bladder. Okay. Yes. Sigmoid mesocolon. The B is sigmoid mesocolon. BL is bladder. No break. Huh? I have to finish the peritoneum. Wait, 2:30 I'll give you the break. I have to finish this peritoneum. I have to finish this part. And then that arrow is the epiploic foramen. Arrow is the epiploic foramen. I have to finish the MCQs on the peritoneum. R is rectum, UT is uterus and BL is bladder. Rectum, uterus, bladder. So the pouch is known as the rectouterine pouch and the utrovesical pouch. Okay, just one last thing you label here. This one, this one. This I'll tell you later. Just label this as the superior layer of. Yes. Superior layer of coronary ligament. Now what is that? I'll tell you after some time. Superior layer of coronary ligament. That's a reflection of peritoneum from the diaphragm to the liver like this. From the diaphragm, the peritoneum gets reflected to the liver, and this is what we call as the superior layer of coronary ligament. And this is what we call as the inferior layer of coronary ligament. Inferior layer of coronary ligament. Now what is that? I'll tell you later. Superior and inferior layer, I can't explain that right now for you, but I'll just keep this in mind. Later I'll be telling you what is superior, what is inferior layer of coronary ligament. Okay, that's it. Now have a look at the slide. Look, this is so nice. Just try to understand the slide, okay? Try to understand this. The same sagittal section you've drawn now. You just drawn this section. We've just drawn this section. Look how difficult slide it is. We've just drawn this slide. So once you draw this now, your concept becomes clear. Then to visualize the slide becomes very easy. Okay, I start here. That's the sagittal section. This is the sagittal section. Just have a look. Okay, I'll start. Oh, great. Very nice. Very nice. Jipper is done. Fine. Okay, I'll start. Here we start and just concentrate on this slide now. Okay. Now that's the liver. Oh, 1 minute. I'll just take this blank. Yep. Starting here, that's the liver. That's the stomach, that's the transverse colon, this is the pancreas, okay? This is the liver. Yo, look here once again. That's the liver, that's the stomach, that's the transverse colon, that's the pancreas. Now what is this structure that is drawn? That's an organ which is present below the pancreas. An organ which has got a lumen. Who's below the pancreas? Who's above and below the pancreas? The duodenum. So this should be the duodenum. Okay, I had not drawn this. This would be the duodenum. Fine. What are these? What are all these? What are all these? These are the small intestines. These are the small intestines. And what is this? What is this? Mesentery. This is the mesentery. Okay. Starting here now. Just look. I'll start. We start from the liver. We come down here. What's that? Lesser omentum. The lesser omentum comes down, it splits, it encloses the stomach here. And now we're going down. What's this? Greater omentum. The greater omentum, for a short distance, it goes and comes here. Now what is this? Transverse colon. It splits over the transverse colon here. And what is this? Peritoneum covering the transverse colon known as? This is known as the transverse mesocolon. The transverse mesocolon goes over and splits over the pancreas. A layer of peritoneum will cover the pancreas, will cover the posterior abdominal wall, will go up to the diaphragm and will get reflected back to the liver like this. Okay. Now you tell me, this is so small. Look, this is so nice. What is this that I've drawn for you? This is the lesser sac. Okay, that's the lesser sac. Clear now? It's a very small area. That's the lesser sac. And now tell me, the peritoneum, the second layer of peritoneum covers the duodenum, gives mesentery to the small intestines. He has not drawn that inverted V-shaped structure. What was that? Transverse mesocolon. He has not drawn that here. The peritoneum now covers the rectum and now covers the bladder. What is this pouch? This is the rectovesical pouch. It's a male pelvis. Uterus is not here. It's a male pelvis. So this pouch is going to be the rectovesical pouch. Here we come in front and the peritoneum goes to the umbilicus, goes straight up, goes to the diaphragm and gets back to the liver. Look how nice. And what is all this in front? This is the greater sac. Okay, this is all the greater sac. Is this clear to all of you? Greater sac and lesser sac. Yes? Now just try to understand. I'll give an orientation to you. Clear now to all of you? Yes, what do you say? Clear to all of you? Okay, very good, very good. Pancreas goes from the right to the left side. Pancreas goes from the right to the left side. It's a big organ from the right to the left side. Okay, fine. Now just have a look and try to understand the slides. Look, these are very good slides. I'll start now. Okay, I start. Tell me now. We open the anterior abdominal wall. Now we open the anterior abdominal wall, and what are we looking into? Look at this now. We open the anterior abdominal wall. One moment. Here, we've opened the anterior abdominal wall, and what are we looking into? Just one moment. Here, that's a slide. Here, we open the anterior abdominal wall, and what is this? What is this that we're looking into? What is this that we're looking into? Tell me. We open the anterior abdominal wall, and what are we looking into? Don't tell me abdomen. Don't tell me abdomen. Yes. What are we looking into? I'll put the slide later. You just answer this now. The moment we open the anterior abdominal wall, what is this that we are looking into? No, we are looking into the greater sac. The moment we open the anterior abdominal wall, what is that we are looking into? Greater sac. Look, this is the greater sac. We are looking right into the greater sac. You're following this? One moment, I'll just show you. Just be clear with your concepts now. Be clear with your concepts now. One moment, just see this and try to understand this. Look here, what I'm telling you is, the moment we open the anterior abdominal wall, we are right here, and what is this? This is the greater sac. That's the greater sac. The greater sac lies between what? The stomach and the anterior abdominal wall. So the moment we open the anterior abdominal wall, we are right into the greater sac. We are right into the greater sac. This concept should be clear. Look here. So, oh my God, this keeps on. So what is this, you tell me? What is this? I can't magnify more than this. Okay, I can just magnify this much for you. So what is this that we're looking into? Greater sac. And now who's behind the stomach? Who's behind the stomach? Who's behind the stomach? Lesser sac. And look, what is this opening? What is this arrow? This arrow is the epiploid foramen. You're following this now? This arrow is the epiploid foramen. That means from the greater sac, if you have to go into the lesser sac, you have to pass through the you have to pass through the epiploid foramen, and we are right behind the stomach into the lesser sac. You're following this? From the greater sac, we go to the right side, we enter the epiploid foramen, and we are right into the lesser sac. That's behind the stomach. Clear? So the moment we open the anterior abdominal wall, what are we looking into? Greater sac. Now we'll lift this greater momentum, we'll lift the stomach. I just have to keep on shifting between the slides. Just have a look. Now you tell me, we'll lift this greater momentum, we'll lift the greater momentum, and we'll lift the stomach. Okay, what are we looking at now? We'll be looking at what are these behind? This is the small intestine. The moment we lift the greater momentum, what are we looking behind at? Small intestines. And the moment we lift the stomach, what are we looking at? Transverse colon. You're following this? Now see here, see the slide simultaneously and understand. Okay, here. Now, we'll lift this greater momentum. And who's behind the greater momentum? Small intestines. We'll lift the stomach up. Who's behind the stomach? The transverse colon. Just have a look at this. Here, look, this is so nice. One moment. Here we are. So here, tell me now, we have lifted the greater momentum, and what are you seeing behind the greater momentum? Small intestines. We lifted the stomach, and who's behind the stomach? The transverse colon. Now you can lift all the small intestines outside the abdomen. You can take all the small intestines outside the abdomen, and we get the attachment of the root of mesentery. You can remove all the small intestines outside the abdomen, and this is what is known as the root of mesentery. You can see this root of mesentery. Root of mesentery is attachment of the mesentery to the posterior abdominal wall, and this root of mesentery, that's the attachment of the mesentery to the posterior abdominal wall. It extends from the DJ flexure. The DJ flexure, that's on the left side, it goes oblique to the right sacroiliac joint. The right sacroiliac joint. What is this root of mesentery? I'll tell you. Just wait. And look at this. All these organs that you're looking at. Look at this. All these organs that you're looking at. These are the retroperitoneal organs. They lie behind the peritoneum. So this is what we call as the retroperitoneal organs. Now, which is the list? What is the list of retroperitoneal organs? I'll start. Don't write anything, just concentrate. Which are the retroperitoneal organs? 1. These are the kidneys. These are the suprarenal. This is the duodenum. That's the pancreas. That's the ascending colon. That's the descending colon. This is the aorta, and that's the IVC. So these is the list of retroperitoneal organs. They are all behind the peritoneum. You following? All these MCQs are very important, and this you have to know. Look here once again. What is the list of retroperitoneal organs? One is the suprarenal, the kidney, the duodenum, the pancreas, the ascending colon, descending colon, aorta, and IVC. And if you can tell me, what is this muscle that you're looking at? What is this muscle? This muscle is the psoas major. Psoas major. Yes. And there's someone who's lying on the psoas major. Tell me, who's lying on the psoas major? This is there in your brain now. I've shown you this. Who's lying on the psoas major? Answer this. Answer this. Spleen is intraperitoneal. Spleen is not retroperitoneal. Who's lying on the psoas major? Answer, the genitofemoral nerve. That we know. So, who lies on the psoas major? Genitofemoral nerve. Genitofemoral nerve. Yes, very good. Very good. Genitofemoral nerve. Okay, fine. Just keep the genitofemoral nerve aside. We know this. The genitofemoral nerve lies on the psoas major. There's something else who lies on the psoas major. What's that? The ureter. Remember, the ureter lies on the psoas major, and these ureters are completely retroperitoneal. This should be very clear. Okay. Retroperitoneal structure will be ureter. Genitofemoral nerve is there. The ureters are also retroperitoneal. So what is the list of retroperitoneal organs? Once again, the kidneys, the suprarenal, the duodenum, the pancreas, the ascending colon, the descending colon, the aorta, IVC, and the ureter. Am I clear? Then one student asked me, so what about transverse colon? You told ascending colon and descending colon are retroperitoneal. What about transverse colon? Now we have drawn such a beautiful diagram there. The sagittal section, we have put the transverse colon in the peritoneum. And what is the peritoneum of the transverse colon known as? Transverse mesocolon. So transverse colon is intraperitoneal. You're clear to all of you? Fine, very good. And now you tell me, one thing, here, one moment. Tell me, what is this structure that I'm showing you? What is this structure? Just have a look. So this will complete my peritoneum. Okay, very good. You tell me now, what is this structure that I'm showing you? This now? I don't know what has happened to this. I can magnify this. Fine. Okay, I'll just magnify this much for you. What are these two lines which you're seeing? These two lines. Look at these two lines. This is known as the root of mesentery. These are all very important visual slides. This is what we call as the root of mesentery. Root of mesentery. Okay. And this root of mesentery extends from, this is the duodenum. After this will be the jejunum. Okay. It extends from the DJ flexure. That's the duodenum of jejunal flexure. And it goes to the right sacroiliac joint. Right sacroiliac joint. What are these two lines indicating? This is one line and this is one line. What are these two lines indicating? Now understand this. What are these two lines? Look, what I'm telling you. Look, the peritoneum will be coming like this, like this. The peritoneum is covering the posterior abdominal wall like this. The peritoneum now along this line, along the first line, there were two lines, you remember? The peritoneum is coming like this, like this, like this, along the first line. Along the first line, the peritoneum gets reflected. It gets reflected. It encloses the small intestines, and it comes back and gets attached to the second line, and then it goes down. And these two lines is the root of mesentery. You're following? Along the first line, the peritoneum goes, encloses the small intestines. Along the second line, it comes and gets attached. These two lines is known as the root of mesentery. You're following? What is the meaning of root of mesentery? Okay, it is the attachment of the small intestines to the posterior abdominal wall. That's the root of mesentery. And what are the structures which the root of mesentery is going to cross? Understand, the structures crossed by the root of mesentery. Another very important MCQ. Structures crossed by the root of mesentery. One is this. You tell me, what is this? Yeah. What is this part of the duodenum? That's the third part of the duodenum. Structures crossed by the root of mesentery. That's the third part of the duodenum. Second, aorta. Third, IVC. Fourth, right psoas major. And who was lying on the psoas major? The right ureter. Right ureter. So what are the structures crossed by the root of mesentery? One is the structures crossed by the root of mesentery. One is the third part of the duodenum. Third part of the duodenum. That's the third part of the duodenum. Aorta, IVC. That's the right psoas and the right ureter. The right ureter. Clear? I'll tell you that. That's two lines, those two lines. See, I'll make it clear. What is this now? This is the peritoneum. Okay, this is the peritoneum covering the posterior abdominal wall. Just one moment. This is the peritoneum covering the posterior abdominal wall. Now, as it comes on this line, as it comes on the first line, it gets reflected. It gets reflected. It encloses the small intestines, and again comes and gets attached to the second line, and the peritoneum will be going down from here now. So this line is known as mesentery covers the small intestines. So anything which the peritoneum encloses is intraperitoneal. No, it's intraperitoneal. Clear to all of you? So these are some MCQs. Fine, just wait, don't sit and talk. We'll discuss it later. Just wait, concentrate on these topics first. Don't type anything. Okay, just listen. I'm telling you something important. You have to concentrate, and then you keep on asking doubts. Clear? Concentrate, you'll understand this. Okay, start now. Some MCQs on the peritoneum, so that completes my peritoneum then. Starting with the retroperitoneal organs. Retroperitoneal organs. 1. Suprarenal, kidneys, suprarenals, kidneys, duodenum, except small area, just write this and I'll explain. Small area of the entire duodenum is retroperitoneal except a small area of the first and the fourth parts. Now how that is, I'll tell you. Pancreas, ascending and descending colon, aorta and IVC, ureters. Okay, so these are the retroperitoneal organs. So suprarenal, kidneys, the duodenum, except a small area of the first and the fourth part. What is the meaning of this? Look, the peritoneum comes down, encloses the stomach. This we know. And as the peritoneum encloses the stomach, it also encloses a small area of the first part of duodenum. Okay, it also encloses a small area of the first part of the duodenum. So first part of the duodenum is half intraperitoneal, half retroperitoneal. That's how it is. And after the duodenum, what begins? Jejunum. And the jejunum is covered by what? Mesentery. Mesentery, the jejunum is covered by mesentery. So when the peritoneum is going to cover the jejunum, it also covers a small area of the fourth part of the duodenum. And so that is how a fourth part of the duodenum becomes partially intraperitoneal. So the statement is like this: the entire duodenum is retroperitoneal except a small area of the first and the fourth parts. Clear to all of you? Next, starting with root of mesentery. Root of mesentery extends from DJ flexure. DJ flexure is duodenojejunal flexure. Pancreas is not covered. Pancreas is totally retroperitoneal. Pancreas is totally retroperitoneal. Pancreas begins from the second part. It is from the second part. Okay. Extends from DJ flexure to right sacroiliac joint. Extends from the DJ flexure to the right sacroiliac joint. Liver is covered by peritoneum. Liver is covered by peritoneum. I've drawn the peritoneum going on the liver. No, I've drawn everything. Just have a look at the slide. I have given you the list of retroperitoneal organs. Anything other than that is intraperitoneal. Okay. And the rectum, uterus and bladder, they are below the peritoneum. They are said to be subperitoneal organs. So organs are classified into three types. One is intraperitoneal, totally within the peritoneum. One is retroperitoneal, totally behind the peritoneum. And the third group is known as the subperitoneal. They are below the peritoneum. That's rectum, uterus and bladder. The peritoneum covers them. It's like that. Clear? So root of mesentery. Hepatic and splenic flexure are retroperitoneal. Okay. So root of mesentery extends from DJ flexure to the right sacroiliac joint. Chalo fast you write. Structures crossed. One. Third part of duodenum. Third part of duodenum. Second. Aorta. Third. IBC. Fourth. Right psoas. Major. You have to look at the slides again and again. Only then you'll remember this. Right ureter. Right psoas major and the right ureter. Right psoas major and the right ureter. I'll tell you that later. Whatever you not understood is fine. I'll tell you that later. Just wait. We'll finish this fast. So structures crossed by the root of mesentery is the third part of the duodenum, the aorta, IBC, right psoas major and the right ureter. Okay, be fast. See this slide and just try to understand this. Okay, I'll start. Look at this slide and tell me. Now look here, which is this part of the duodenum? Which is this part of the duodenum? That's the third part of the duodenum. Just 10 more minutes, I'll finish. This is the third part of the duodenum, third part. Now tell me, third part of the duodenum is crossed by whom? So first part of duodenum you know, second part of duodenum you know. You just see the slide and tell me, who's crossing the third part of the duodenum? What are these vessels? The superior mesenteric vessels. So the superior mesenteric vessels are crossing the third part of the duodenum, also crossed by, what is this? The root of mesentery. Root of mesentery. Okay. So third part of the duodenum would be crossed by the root of mesentery. So anterior relation of third part of duodenum was going to be what? One, the superior mesenteric vessels and the root of mesentery. And what will the posterior relation of third part of duodenum be? One, what is this? The psoas major. Which psoas major is this? The right psoas major. And who was lying on the psoas major? What was this structure that I had drawn? The right ureter. The right psoas major and the right ureter. This is the IVC and that's the aorta. So that becomes the posterior relation of the third part of the duodenum. You understanding? I have not started the duodenum as yet, but still you know now the entire duodenum. So that completes it. So tell me now, the third part of the duodenum, anterior relation would be the superior mesenteric vessels. You know, this superior mesenteric vessels are also related to what? What is this part of the pancreas known as uncinate process of pancreas? So uncinate process of pancreas, the same superior mesenteric vessels will be crossing the anterior part of third part of duodenum. The third part of the duodenum is also crossed by root of mesentery. The posterior relations of third part of duodenum, one, the right psoas major and the right ureter, the IVC and the aorta. Understand? That's how you remember the duodenum. Okay, starting with the next, epiploid foramen. Ureter is retroperitoneal. Starting with epiploid foramen. And just one more thing I have to tell you, so that will complete my peritoneum. Okay, starting with epiploid foramen. Just be fast. You know this epiploid foramen? Epiploid foramen. Boundaries: anterior, lesser omentum containing hepatic artery, portal vein and bile duct. Lesser omentum containing hepatic artery, portal vein and bile duct. Posteriorly is the IVC. This I told you. You are understanding this now? So anteriorly is the less omentum containing three structures: hepatic artery, portal vein and bile duct. But suppose you have to select one out of this three. If you select one out of this three, you always select it as portal vein because that's the immediate anterior boundary. Okay? But we always say this together. Posteriorly is IVC. Go slightly behind the IVC. That's the right suprarenal gland. Right suprarenal gland and the body of, I'll show you the slide, body of T12 vertebrae. Body of T12 vertebrae. Superior is the liver. Superior is the liver. Caudate lobe of liver. And inferior is the first part of duodenum. Inferior is the first part of duodenum. Okay. Greater and lesser sac, we have drawn the slides, so you'll understand where does it end. No? Lesser sac is behind the stomach and in front of the stomach bed. Lesser sac is behind the stomach and in front of the stomach bed. Suprarenal. I'm so sorry. Suprarenal above. Suprarenal. Okay. So lesser sac is behind the stomach and in front of the structures forming the stomach bed. In front of the stomach bed. Caudate lobe of liver. I'll show you the slide. It's the caudate lobe of liver. See this slide and just try to understand this. That's the epiploid foramen. Look at the slide, you'll understand. Just have a look here. Have a look here. So this is the greater sac. What are we looking into? This is the greater sac, right? This is the greater sac. And who's behind the stomach? Where is the lesser sac? It's right behind the stomach. And from the greater sac, if you have to go into the lesser sac, you have to pass through this epiploid foramen. Okay, you have to go through this epiploid foramen. So what are the anterior boundaries of epiploid foramen? The lesser omentum. Look at that. That's the lesser omentum containing hepatic artery, portal vein and bile duct. What is the superior boundary of epiploid foramen? Formed by the lever. This is the lever, and there's a lobe of the lever here. That's the caudate lobe. I'll show that later. Caudate lobe of lever. And who's below? Who's below here? That's the first part of duodenum. So this is the epiploid foramen. That's the first part of the duodenum inferiorly. Look, this is the epiploid foramen here. Who's the immediate posterior relation? IVC. What is this? Suprarenal gland. That's the suprarenal. And this is the body of T12 vertebrae. Body of T12. Okay. So anterior boundary of epiploid foramen are these three structures, and these three structures are present in lesser omentum. But if you see out of these three structures how nicely he has drawn, the most and the immediate anterior is portal vein. Okay. Who's behind? Who's behind? One is the IVC, the right suprarenal gland and the body of T12 vertebrae. And this is the caudate lobe of lever, caudate lobe of lever, and this is the first part of duodenum. Just a diagrammatic representation. This is okay. And just one last thing I'm telling you, then we stop here. Just one last thing. Okay, understand this now. Okay, understand this now. The last thing, and this is very important. Everything is important that way. Okay, here I start. Tell me now, what are the contents of umbilical cord? Just 5 minutes. I'm finishing this. 5 minutes. What are the contents of umbilical cord? Contents of umbilical cord. There are 2 arteries and 1 vein. Contents of umbilical cord: 2 arteries and 1 vein. Which vein is that? Which vein is that? Don't tell me umbilical vein. Which vein is that? 2 arteries and 1 vein. Which vein is that? The left is left. The left is left. Okay, no? So 2 arteries and 1 vein. The left umbilical vein. So what are the contents of umbilical cord? That's the umbilical cord. It has 2 arteries and 1 vein. So this I'm drawing as the umbilical arteries. There are 2 umbilical arteries and 1 umbilical vein. The left is left. The left umbilical vein. Yes, I'm splitting up. The left umbilical vein. Now this left umbilical vein goes and joins with what? The left umbilical vein goes and joins with, look, this is the lever here. I'll just make this as the lever for you. That's the lever. And I'll just make this as the portal vein. That's the portal vein. That's a portal vein. Okay, so the left umbilical vein goes and joins with the left branch of portal vein. It goes and joins with the left branch of portal vein. Clear? So that's the left umbilical vein. It goes and joins with the left branch of portal vein. What does the left umbilical vein carry? This is a very important topic. Just concentrate. Do not sit and type there. What are you sitting and typing? Don't type anything. Just listen. Who's interested in the ale of sacrum? What am I teaching you? Why are you asking me ale of sacrum? Just wait. Don't sit and discuss. Okay, so that's the umbilical cord, 2 umbilical arteries and the left umbilical vein. The left umbilical vein goes and joins with the portal vein, the left branch of portal vein. What does the umbilical vein carry? Pure blood. If this pure blood goes to the portal vein, from the portal vein the blood will go to the liver. The liver will use all this pure blood for its own metabolism and no blood will go further. So the entire blood should not go to the liver. Who's this? This is the IVC. And there's a bypass here. What is this bypass known as? From the left umbilical vein to from the left branch of portal vein to the IVC. And this is what we call as the ductus venosus. From the left branch of portal vein, the blood is taken to the IVC. There's a bypass and this is the ductus venosus. Where does the blood come now? Don't draw this, just wait. Where does the blood come? To the IVC. From the IVC, the blood goes to the right atrium. From the right atrium, the blood directly goes to the left atrium through foramen ovale. This you know, the blood goes to the left atrium through foramen ovale. From the left atrium, the blood goes to the left ventricle. From the left ventricle to the aorta. From the left ventricle, the blood goes to the aorta. Aorta divides into common iliacs. Aorta divides into common iliacs. Common iliac further divides into, aorta will divide into two common iliacs. Okay, I'll make it like this. Aorta divides into common iliac. Common iliac will further divide into an external and internal iliac. External and internal iliac. Internal and external iliac. Okay. So this is clear. And from the internal iliac, two arteries arise. From the internal iliac, these are the umbilical arteries which comes here. So umbilical arteries are branches of what? Internal iliac artery. Umbilical arteries are branches of internal iliac artery. This is clear. Now suppose if the blood, from the right atrium, the blood goes to the right ventricle. From the right ventricle, it goes to the pulmonary trunk. From the right ventricle, it goes to the pulmonary trunk. And from the pulmonary trunk, it will go to the lungs. But the lungs are not functioning here. Again, there's a bypass here. And what do you call this bypass as? This is what we call as the ductus arteriosus. Remember how the ductus arteriosus is formed? Ductus arteriosus is derived from the left. Yes, ductus arteriosus, you remember? The left sixth arch artery between the lung bud and the dorsal aorta. The left sixth arch artery, yesterday I told you that, the left sixth arch artery between the lung bud and the dorsal aorta, that forms the ductus arteriosus. Okay, that's ductus arteriosus. What is this that I have drawn for you? This is the fetal circulation. Okay. That's the fetal circulation. Just draw this first. Ductus arteriosus. This is ductus venosus. This is foramen ovale. D is ductus arteriosus. This is common iliacs. Okay, is this clear to all of you? Is this clear? So that's fetal circulation. Okay, I'll start now. Just concentrate. Just 5 minutes. Just concentrate. This will be done. So my peritoneal part is done. So this is the fetal circulation. And just tell me, the umbilical arteries begin from where? Umbilical arteries will begin from the pelvis. Umbilical arteries, the internal iliac arteries are where? In the pelvis. And the umbilical arteries are beginning from the pelvis. They begin from the internal iliac and they're going up towards the umbilicus. And as they're going up towards the umbilicus, on the way comes the urinary bladder. Okay, on the way, that's the urinary bladder which comes here. So the umbilical arteries begins from the internal iliac and they're going up towards the umbilicus. On the way comes the bladder. So one artery goes from this side of the bladder, one artery goes from this side. So both the umbilical arteries go on either sides of the bladder to the umbilicus. You're clear? So that's the bladder. Now see, after birth what happens? You're clear with this? I'll tell you, jejunum and ileum are intraperitoneal. Wait, okay, I have to finish this. Now tell me, after birth what happens? This is fetal circulation. After birth, this goes off. This is the obliterated left umbilical vein. And this obliterated left umbilical vein is now known as the ligamentum teres. And this ligamentum teres lies on what? The falciform ligament. Clear? So, obliterated left umbilical vein is ligamentum teres, lies in the falciform ligament. Ductus venosus becomes what? The ligamentum venosum. The foramen ovale becomes what? The fossa ovalis. The ductus arteriosus becomes what? The ligamentum arteriosum. And look, this is so nice. This part of the umbilical artery from the umbilicus to the bladder, from the bladder to the umbilicus, this part of the umbilical artery from the bladder to the umbilicus obliterates off, and this is what we call as the obliterated umbilical artery, and this is what is now known as the medial umbilical ligament. The same medial umbilical ligament which was dividing the Hasselback's triangle into two parts. A hernia going from that side was known as lateral direct, and a hernia going from this side was known as a medial direct inguinal hernia. Okay, this is the obliterated umbilical artery, the medial umbilical ligament, right? And now you tell me, what is this? What is this? This is the non-obliterated part of umbilical artery. The non-obliterated part of umbilical artery will begin from where? It begins from the internal iliac. It goes up towards the bladder. From the internal iliac to the bladder, it now supplies the bladder. It is now known as the superior vesical artery. Superior vesical artery. Okay. There are two umbilical, yes, Bhanu Bakshi, there are two umbilical arteries and two umbilical veins. One vein disappears early in life, so the left umbilical vein is left. Okay, clear to all of you? So this is about the fetal circulation. Just write this down and finish this. This should be clear. Obliterated left umbilical vein. Just read fast. This completes. Obliterated left umbilical vein is ligamentum teres. What, Mayuri Deshmukh, what did you not understand? Pelvic part. The umbilical arteries, when they are going from the internal iliac, they are going up towards the umbilicus. They pass on either sides of the bladder. One goes from this side, one goes from this side. As both the arteries goes on either sides of the bladder. So obliterated left umbilical vein is ligamentum teres. Ductus venosus, ligamentum venosum. Foramen ovale, fossa ovalis. Ductus arteriosus, ligamentum arteriosum. Obliterated non-obliterated part of umbilical artery, it will extend from where? Internal iliac. And where will it go to? It extends from internal iliac to the bladder, no? It now supplies the bladder. It is now known as superior vesical artery. Superior vesical artery. Understood now? So this is fetal circulation, and this completes my peritoneal part. So we've done the posterior abdominal wall, anterior abdominal wall, we've done the peritoneal reflections with some orientation of the organs, and now we are entering into the abdomen. We'll now go into the abdomen after the break. Okay, just one thing for those who have not understood that route of mesentery, just 2 minutes, listen here, then you take a lunch break. Okay, look, what I'm telling you is, see, peritoneum and peritoneum. Look, peritoneum covers the posterior abdominal wall. Look, I'll just show you like this. Okay, look, this is the peritoneum. Look, the peritoneum is covering the posterior abdominal wall like this. It is covering the posterior abdominal wall, then it gets reflected. So this line, it will get reflected along this line like this. This line which extends from the digit flexure to the sacroiliac joint. The peritoneum is covering the posterior abdominal wall like this. Along this line, the peritoneum goes forwards. It encloses the small intestines and now comes back and gets attached to the second line there, and then it goes down. Understood now? And that line, the first line, the peritoneum gets reflected, encloses the small intestines and comes and gets attached to the second line, and then it goes down. And then you'll see this line here, and this line is known as the root of mesentery. I hope this should be clear now. Look, the peritoneum is this is covering the posterior abdominal wall. Along this line, the peritoneum goes in front, encloses the small intestines, comes back like this and gets attached to the second line and now goes down. And this line is known as the root of mesentery. Is this clear now? Okay. Fine to all of you. Okay, that's it. Take a break then. 3:15 I'll start. 3:15. I'll put the slide. 3:15. Yellow part are all the degenerated parts. The degenerated parts are the yellow parts. Okay, that's good. Take a break then. Fine. 3:15. Break till 3:15. Okay. Then we start to. Okay. This is the superior vesical artery. The superior vesical artery will begin from internal iliac to the bladder. This is the superior vesical artery. The yellow part are the degenerated parts. Okay. Starting with the organs, the important organs and the embryology of the organs. Okay. Now about the stomach. You know the blood supply of the stomach. Now, you know the stomach bed, you know the blood supply of stomach. Look, along the lesser curvature, there's an anastomosis between two arteries. What is that? The left gastric and the right gastric artery. Along the greater curvature, there's an anastomosis between two arteries, the left gastroclephoid and the right gastroclephoid artery. The fundus of the stomach is supplied by short gastric branches of splenic artery. Okay, now understand this now. Stomach bed is also known to you. Just see this. So now you know foregut, you know midgut, you know hindgut. Tell me now, stomach develops from which part of the gut? Stomach develops from the foregut. You know foregut, midgut and hindgut. I've told you all these things. So stomach develops from the foregut. Now, when the stomach forms, the stomach is like this. I'll make a full screen and just try to understand this. Development of stomach. Understand the development of stomach. We're starting with stomach, development of stomach. The rest of the things of the stomach I've told you. Listen now, the stomach develops from the foregut. When the stomach develops in an embryo, see the embryo is folded like this, so the stomach is like this. If the embryo is folded like this, the stomach is like this. On the ventral aspect of the embryo, the stomach is like this. Now this stomach is attached to the posterior abdominal wall and this stomach is attached to the anterior abdominal wall. Like the entire GIT is attached to the anterior abdominal wall and to the posterior abdominal wall, right? So what is this known as? The ventral mesentery. And this behind is known as the dorsal mesentery. You remember where have we come across this mesentery? Dorsal mesentery, I've told you somewhere, dorsal mesentery of esophagus. And this dorsal mesentery of esophagus takes part in the formation of what? Diaphragm, dorsal mesentery. So now the stomach is like this. I'm showing you the embryo is sitting like this, and in the sitting position, that's how the stomach is. Now the stomach has got two ends here, two surfaces here, two borders like this. Okay, so now I start. What is this surface? The right surface, that's the left surface. Two borders, the anterior border, the posterior border, and two ends, the cardiac end and the pyloric end. What is attached from the stomach to the anterior abdominal wall? This way, this is the ventral mesogastrium. And who's behind here? That's the dorsal mesogastrium. Okay, now the stomach undergoes a rotation. The first rotation is along this axis. What is this axis? A vertical axis. The stomach undergoes a rotation like this, like this, like this, like this. Okay, so now you tell me which is this surface. The left surface now becomes what? Anterior. The left surface now becomes anterior and the right becomes posterior. That's the first rotation of stomach. The first rotation is along the vertical axis. The stomach turns like this. So the left surface becomes anterior and the right becomes posterior. Okay. In actual us, if you see, these two ends are not lying in the same straight line. So now the stomach undergoes second rotation. The cardiac end and the pyloric end in us are not in the same line. No? Now the stomach undergoes a second rotation, and the second rotation is along this axis. What is this? Anteroposterior axis. The stomach turns like this, like this, like this. So the pylorus comes to lie at the higher level. The pylorus goes upwards at a higher level. The left border grows rapidly and forms what? The greater curvature. So this is how the stomach develops. The first rotation is along a vertical axis. The stomach undergoes a rotation like this. The left surface becomes anterior and the right becomes posterior. The second rotation is along an anteroposterior axis. The stomach turns like this. The pylorus lies at a higher level. The left border grows rapidly to form the greater curvature. Okay, now understand one more thing. As what is this attached to the stomach from the anterior border to the anterior abdominal wall? That's the ventral mesogastrium. And what is behind here? Dorsal mesogastrium. Now just understand this. As the stomach is turning like this, like this, like this, the ventral mesogastrium, which was straight, goes to the right side like this. And the dorsal mesogastrium, which was straight back here, look at what happens. As the stomach is turning, the dorsal mesogastrium goes on this side. As the stomach further turns, the dorsal mesogastrium further goes to the left side. The dorsal mesogastrium further goes to the left side. And that's how a space is formed behind the stomach. And this is what we call as the lesser sac. So understand how the lesser sac is formed. Lesser sac is formed because of the rotation of the stomach. Look at this slide, it will be clear. Look at this slide. Look. Now what is this? This is the ventral mesogastrium. Ventral mesogastrium. Mesentery, a general term. In case of stomach, this would be known as mesogastrium. Ventral mesogastrium, that's a dorsal mesogastrium. Now the stomach is turning, and what is happening to the dorsal mesogastrium? Dorsal mesogastrium is straight like this, and as the stomach is turning, the dorsal mesogastrium goes to the left side like that. The dorsal mesogastrium further goes to the left side like this, and that's how a space is formed behind the stomach, and this is what we call as the lesser sac or the omental bursa. Understand? So the lesser sac is formed just because of rotation of stomach. Understood? Now something else I'm telling you, have a look. Understand this now. Now just see the slide. This is a diagrammatic representation for you. Okay, look at this now. Okay, I'll start. This is just a representation. This is the stomach. That's the stomach. What is this to begin with? This is anterior abdominal wall and this is the posterior abdominal wall. So this is one like this and this is something like this. Okay, the slide is later. The focus will come. It will be focused. So this is what we call as the ventral mesogastrium and this is what we call as the dorsal mesogastrium. This is how it is. So what develops in the ventral mesogastrium? There's someone who's forming in the ventral mesogastrium. Who's that? The liver. The liver grows in the ventral mesogastrium. No. The liver is not formed by the ventral mesogastrium. The liver is not developing from the ventral mesogastrium. No, the liver is derived developing from the gut. From the GIT you get a small diverticulum for the liver. We call this as the hepatic diverticulum, and this hepatic diverticulum will be growing towards the ventral mesogastrium. The liver is derived from the GIT. What is the lining of GIT? The entire GIT is lined by what? Endoderm. Remembering, the GIT is endodermal in origin. So all the small diverticula which are derived from the GIT are therefore what in origin? Endodermal in origin. These are all endodermal in origin. That is, the liver is derived from the GIT. The liver is endodermal in origin, and the liver and this hepatic diverticulum will be migrating towards the ventral mesogastrium. And this liver grows in the ventral mesogastrium, and the moment the liver forms in the ventral mesogastrium, it divides this ventral mesogastrium into two parts. Look, this is one from the anterior abdominal wall to the liver. This is one, and the second part is from the liver to the stomach. We now call this as, what is this now known as? Falciform ligament. This is now known as falciform ligament. So that fold of peritoneum which extends from the anterior abdominal wall to the liver is now known as falciform ligament. And from the liver to the stomach, this is what we now call as lesser omentum. Lesser omentum. You understanding? That means this falciform ligament, the lesser omentum, these are all derived from ventral mesogastrium. Ventral mesogastrium. Okay. Something else is also derived from the ventral mesogastrium. We'll see this as we now go into the topics. Understand this now. Starting with the development of the stomach. Start. The rest of the things I'll repeat this. You will start with development of stomach. I'm starting with the organs now. The important organs I'll tell you. Stomach bed we have done. Blood supply of the stomach, Okay, starting with the development of stomach. Develops from foregut. Develops from the foregut. It has two ends. It has two ends. That's cardiac and pyloric end. Two borders and right and left surface. Right and left surface. Okay. Now, first rotation along vertical axis. First rotation along vertical axis. Understand this. The left surface becomes anterior. The left surface becomes anterior. You just try and you understand it. The left surface becomes anterior. I'll explain this once again. The left surface becomes anterior and the right becomes posterior. The left surface becomes anterior and the right becomes posterior. The anterior border becomes anterior border becomes right and posterior becomes left. The anterior border becomes right and posterior becomes left. Understanding? Second rotation along anteroposterior axis. Second rotation along anteroposterior axis. The pylorus comes to lie. The pylorus comes to lie at a higher level. The pylorus comes to lie at a higher level. The left border grows rapidly to form greater curvature. Left border grows rapidly to form the greater curvature. Second rotation along the anterior border. Okay. During rotation, the dorsal mesogastrium also shifts to right, to the left, forming lesser sac. Forming the lesser sac. This is very important. Okay, just try to understand this. During rotation, the dorsal mesogastrium also turns to the left, thus forming the lesser sac. Lesser sac, also known as omental bursa. If you're done, you tell me. Yes, what did you not understand, Ramya? Yes, Ramya Rangnath, what did you not understand? Who is this Ramya Rangnath? From where are you? And what have you not understood? Yes, who is this Ramya Rangnath? What did you not understand? Initial part of embryo, you didn't understand. Just wait. If you don't understand, no, this is the easiest way I'm teaching. If you don't understand, you're not fit to be here. And I don't think you have done your MBBS and come. Understand? If you don't understand what I'm teaching and if you're telling it as worse teaching, just get out of here. Understand? Clear? You are worse that you're not understanding. Understood? Think about yourself first. If everyone is understanding and you're not understanding, the problem is lying with you. Nonsense you are. Initial part of embryo, what did you not understand? Are you a fool to talk like this? You come. I'll show you. Understand? If you are not listening, that's not my problem. You do all nonsense things, you type, you do all anything, and then you tell me that you are not understanding and I am teaching worse. I don't tolerate such nonsense. Understood? You may talk this to anyone. I don't tolerate all this nonsense. Whoever you are at your home. Understand? When you're sitting for my lecture, you have to listen to me. Yes, Ramya Rangnath, are you listening to me? Which center are you from? You tell me. Which center are you from? What do you mean by worse teaching? I don't tolerate all this nonsense. You are worse and you are a fool that you are not able to understand. Nothing can be taught easier than this, what I am teaching. Understood? You have a phone doesn't mean that you type any nonsense. Clear? And I know what I teach. And